Welcome to Striving for Consensus, optimizing the current and future management of relapsed refractory diffuse large B-cell lymphoma. This is medical oncologist Dr. Neil Love. For this program, I met with Drs. Martin Hutchings, Manali Kamdar, Matthew Lunning, and Gilles Salles for a roundtable discussion. Subsequent to this recording, the combination of brentuximab vedotin with lenalidomide and rituximab received FDA approval for patients with relapsed diffuse large B-cell lymphoma. To begin our discussion for the roundtable meeting, I asked Dr. Kamdar to discuss the evolving role of CAR T-cell therapy in the management of relapsed refractory DLBCL.
So we're going to discuss the evolving role of CAR T-cell therapy in diffuse large B-cell lymphoma. As the audience very well knows, there are three constructs that have been FDA approved, which are anti-CD19 driven. ZUMA-1 tested axicabtagene ciloleucel, Juliet tested tisagenlecleucel, and Transcend tested lisocabtagene maraleucel. These three constructs were tested in three pivotal studies that were phase 2 in nature in patients that were heavily pretreated with relapsed refractory large B-cell lymphoma. They differ with respect to many things. However, one major differentiating point is the co-stimulatory domain, with axicabtagene ciloleucel having CD28 as a co-stim domain, and Juliet and Transcend investigating tisagenlecleucel and lisocabtagene utilizing the 4-1BB co-stimulatory domain. It does have an impact or a function of toxicity, as we will see, based on the level of expansion of these constructs when they get tested. These are cross comparisons across clinical trials. However, it's very important to point out that the median age on the Transcend study was as high as 86. So a lot of patients ask if they can be eligible for CD19 CAR T-cell therapy, and there's your answer there. The other difference with regards to eligibility criteria was that on the Transcend study, lisocabtagene maraleucel was investigated not only in aggressive large B-cell lymphoma, that was DLBCL, primary mediastinal B-cell lymphoma, and transformed lymphoma, but also in patients who had secondary CNS involvement, as well as patients who had failed a prior allotransplant. Majority of the patients were refractory, primary refractory to frontline treatment, as well as to last line of treatment, as well as refractory to prior autotransplant. These are the overall responses as well as complete responses. These were unheard of back then when these trials got published in such a heavily pretreated relapsed refractory large B-cell population. As you can see, across the three studies, the complete response rate was anywhere from 40% to 53%. With regards to toxicity profiles, they were also quite different, as alluded to on the ZUMA-1, axicabtagene ciloleucel. With regards to any grade neurotoxicity, it was 64%, and any grade or higher neurotoxicity on the axicabtagene study was 32%. With regards to the Transcend study and the Juliet study, you can then tell that it was quite different with regards to grade 3 or higher neurotoxicity in the range of 10 to 12%. With regards to cytokine release syndrome, you can see on the ZUMA-1 study, any grade CRS was seen in 93% on ZUMA-1 versus 42% on the Transcend and Juliet study. Grade 3 or higher cytokine release syndrome was seen in 11% of patients who received axi-cel versus only 2% of patients who received lisocabtagene maraleucel. Now, we do have long-term follow-up data, and as you can see across the three constructs, there is a clear plateau that is beginning to emerge. And at the 5-year mark, axi-cel showed a 5-year overall survival of 43%. Lisocabtagene maraleucel showed a 5-year overall survival of 38%, and so did tisagenlecleucel. So in a heavily pretreated population where patients could have potentially succumbed to their disease, nearly 40% of patients are now being cured with CD19 CAR T-cell therapy in relapsed refractory large B-cell lymphoma. This was our algorithm in 2021, where patients were treated with frontline R chemoimmunotherapy. If they were refractory or relapsed, they were given a second salvage attempt with a non-cross drug resistant chemo treatment. If they're chemosensitive, they went on to an auto. If they were not, they went on to CAR T. Similarly, if they relapsed after an auto, they went on to CAR T cell therapy. However, not all relapses are created equal, and we know this based on the CORAL study. As you can see on the CORAL study, if patients were treated with frontline rituximab and if they relapsed within a year, their overall survival was quite dismal. And then on the right side, you can see the meta-analysis, which is the SCHOLAR-1 data across several retrospective and prospective studies, which looked at high-risk patients, primarily primary refractory, patients who relapsed within 1 year of primary chemoimmunotherapy, and even auto-transplant could not really salvage those patients who, in fact, achieved a remission after salvage treatment. So it was time to move CD19 CAR T cell therapy from the third-line setting to the higher-risk second-line patient population. And with that, with birth of these 3 randomized trials of high-risk second-line relapsed refractory large B-cell lymphoma, and these were identical, although not exactly similar in terms of the comparison and in terms of how they were conducted. ZUMA-7 investigated axicabtagene cilta-leucel versus salvage chemo followed by an auto. That was the standard of care. Transform similarly tested lisocabtagene maraleucel versus standard of care, which consisted of the same. And Belinda study tested tisagenlecleucel versus standard of care. This was tested in transplant-eligible, primary refractory, or early relapsed, diffuse large B-cell lymphoma population. Across the 3 studies, as the audience very well knows, that Belinda was a negative study. The primary endpoint across the 3 studies was event-free survival. ZUMA-7 and Transform were positive studies. And in these positive studies, the standard of care performed quite dismal as compared to CD19 CAR T cell therapy. And based on that, the FDA approved axicabtagene, axicel, as well as lysocel as the new standard of care versus the old standard of care, which used to be auto-transplant in a high-risk primary refractory and early relapsing large B-cell lymphoma population. There were slight differences noted across ZUMA-7 and Transform. For example, on ZUMA-7, steroids were allowed as the only bridging therapy, versus Transform was more akin to real-world data in terms of the fact that 1 cycle of salvage chemotherapy was allowed. Crossover was built on to the Transform study, where 62% of patients actually crossed over to receiving lisocabtagene who progressed on the standard of care arm. You can see across the primary refractory status, between the 2 positive studies, 75% of patients were primary refractory. About 16 to 20% of patients had double hit lymphoma. There were notable differences between manufacturing time, with ZUMA-7 having about a 17-day time around versus Transform having a 34-day manufacturing time. With regards to the median EFS, you can see clearly there was a benefit to CD19 CAR T cell versus standard of care. With regards to complete responses, they were 65% and 74% between ZUMA-7 and Transform respectively. And with regards to toxicity profile, the same theme continues. You can see that the grade 3 or higher cytokine release syndrome and neurotoxicity was higher on the ZUMA-7 study versus the Transform study. 6% CRS, grade 3 or higher, 21% neurotoxicity on the ZUMA-7 study that was grade 3 or higher versus 1% and 4% on the Transform study, respectively. It's also very important to note that a lot of community providers have asked us that what if my patients have achieved a complete remission after receiving the second-line treatment? You can see that across the 3 studies, whether positive or negative, you can see the median EFS for the patients who did undergo an auto-transplant in remission. The median EFS is quite dismal, around 2 to 3 months. And this was also found on the ZUMA-7 and Transform study, where CAR T was actually given in the third-line setting, of course, off protocol on the ZUMA-7 and on protocol on the Transform study. The EFS was lower than what was seen in patients who had CD19 in the second-line setting. This is the primary endpoint across the two studies. I'm not going to focus on the Belinda study because it was a negative study, but this is now at a 4-year follow-up with regards to ZUMA-7. We have an overall survival benefit favoring axi-cel versus standard of care, and thus clearly that's the new standard of care. On the other hand, on the Transform study, you can see there's a difference between the Kaplan-Meier curves at the 3-year follow-up with regards to overall survival. However, there is no statistically significant difference between liso-cel and standard of care. And I think that is primarily because of the crossover that was built in. 62% of patients crossed over on protocol. And it was not quite like real world, where the manufacturing started after they got diagnosed with refractory disease post-auto. These patients were collected well before. As a result, they were able to get the CD19 product right away. So the big question then is, what do we do for patients in the setting if they were transplant ineligible? And the pilot study investigated liso-cel in the second-line study, in the second-line setting for transplant ineligible patients. Pilot was a phase 2 open-label study with the primary endpoint of overall response rate. 74 patients were enrolled, of which 61 received liso-cel, with a median age of 74. Of course, octogenarians were involved and enrolled on this study. ECOG-2 was present in about 25% of patients. Heavily primary refractory patients, 54%. Relapse within the first 1-year mark was about 21%. And you can see at a median follow-up of 18 months, the primary endpoint was met. The overall response rate was remarkable at 80% with a CR rate of 54%. And you can see the Kaplan-Meier curves here. I think a big theme that is beginning to emerge with immunotherapies is how do patients do if they were to achieve a complete response? If patients achieve a complete response with these immunotherapy constructs, the duration of response is clearly much better than patients who do not achieve a complete remission. And that's exactly what the pilot study also showed, where the median duration of response of patients who have achieved a CR was not reached versus only 2.1 months in patients who achieved a PR. With regards to the toxicity profile as well, this study showed that patients had no treatment-related deaths. The most common toxicity was cytopenias, low-grade CRS, low-grade neurotoxicity, and thus the FDA also approved liso-cel in the second-line setting for patients who were transplant ineligible. So now we have 3 indications in terms of transplant eligibility in the second-line setting for liso-cel and axi-cel. For transplant ineligible second-line patients, liso-cel is approved, and now we also have 3 constructs, which is liso-cel, axi-cel, and tis-cel in the third-line setting. I'm now going to take you through CAR T-cell therapy toxicities quite briefly, but really focus on some of the major ones that our community partners see in their clinic. So CAR T-cell therapy-related unique adverse events, of course, everyone knows cytokine release syndrome and neurogenic toxicity, also called ICANS. The on-target off-tumor toxicity, which is the B-cell depletion and hypogammaglobulinemia. It's a function of how CAR T-cell therapy works. Delayed hematopoietic recovery, risk of infection because of B-cell depletion and hypogam, and rarely seen toxicities. The FDA has certainly raised a signal, which we will also be talking about. What is cytokine release syndrome? It's basically an acute systemic inflammatory syndrome. Risk factors typically are based on the pretreatment, tumor burden, extranodal sites, of course, the markers of elevated CRP, ferritin, co-stim domains of CD28 technically have a higher CRS than 4-1BB domain constructs. And the signs and symptoms typically feel like the flu initially. So patients have a low-grade fever that can eventually go into shortness of breath, other organ toxicities. But fortunately, the ASTCT consensus guidelines tells us exactly how to manage them. We now have consolidated guidelines with regards to management as well as identification of these toxicities. I think it's very important to remember that with regards to ICANS, the timing can be quite variable, but for the majority, it is concurrent with CRS or right after CRS develops. So if somebody develops a cytokine release syndrome, we typically have these patients hospitalized because it's likely that they might develop immune effector cell-associated neurotoxicity, also called ICANS. Typically, it is usually early, but very, very rarely it may be delayed. Again, the risk factors are quite similar, but the majority of the times it's the antecedent CRS. Signs and symptoms can be quite mild, such as just tremors or mild slurring of speech, but it could also progress to aphasia, stroke-like symptoms. And again, the ASTCT consensus guidelines here help us manage with regards to grading as well as the overall management of CRS and ICANS, primarily rests on the fact that you really have to curb the inflammatory storm. And here for CRS, tocilizumab is first-line treatment. It's an IL-6 receptor antagonist. Corticosteroids are the backbone of how we manage these inflammatory syndromes, and the dosing, etc., is all outlined in the ASTCT guidelines. Very rarely we do encounter management for patients who have refractory CRS and ICANS, and I think in those settings there are data now to suggest that interleukin 1 receptor antagonist, which is anakinra, is very, very effective in mitigating these refractory CRS and ICANS. A handful of times we have to deal with patients who have unfortunately not responded to anakinra, in which case IL-6 antagonists or JAK inhibitors as well have been explored with success. Cartopenia is something that we see as a result of a lot of factors: prior treatments, LD chemo, of course, CRS, ICANS, and then the inflammatory storm. However, we really are able to manage this because the majority of these cytopenias occur usually in the first 30 days. And that's why the patients are at an academic site in the first 30 days. Short-term toxicities, which might last in the form of cytopenias in the first 3 months, can occur in some. It's very rare to have prolonged, which is more than 90 days after CAR-T cytopenias. And Dr. Rajeski and colleagues have developed a really amazing model called the CAR hematotox model that can predict who those patients might be based on the baseline characteristics of chemical of inflammatory levels as well as the baseline cytopenias. In terms of B-cell aplasia and hypogammaglobulinemia, it's an on-target expected toxicity. B-cell aplasia can, however, sometimes be profound and severe, and it manifests as hypogammaglobulinemia in up to 30% of patients. So a lot of times, although there is no unified consensus, a lot of us, if the IgG is less than 400, we prophylactically give our patients IVIG. That's usually for the first 6 months, and after that, the recovery is quite good for majority of patients because they are also at risk for infection. We also prophylax these patients because up to 30% of patients can be at risk of infection for the first 1 year after receiving CD19 CAR-T. Lots of use of growth factor support, as well as making sure that they have antibiotic, as well as PCP and antiviral prophylaxis on hand. This is a very, very rare side effect of CD19 CARs. It may be seen in CD22 CARs. It's called immune effector cell-associated hemophagocytic lymphohistiocytosis-like syndrome, also called IECHS. It's basically HLH that happens in patients with who have received CD19 CARs. Like I said, it's quite uncommon, but we now have guidelines to figure out the definition of this in the setting of CAR-T. And usually, steroids followed by anakinra is the management key to taking care of these patients. In terms of secondary malignancies, fortunately, the rates are similar to expected incidence following traditional chemo or autotransplant because this is a heavily pretreated population who has received chemotherapy. There was, of course, flags that were raised by the FDA rightfully because there were 22 lymphomas that were found in patients who had received 22,000 patients who had undergone CAR-T. They found 22 lymphomas, and these T-cell lymphomas are very, very rare. There were certainly a lot of series subsequently that were published. One that comes to mind is a series from Stanford by Dr. Hamilton and colleagues, which looked at 700 odd patients, and of which they found 1 T-cell lymphoma. I think the big question is, did they find the CAR-T vector? Is it associated with insertion mutagenesis? I think what I got from all of the studies that were done is that sometimes having a CHIP mutation may predispose you to developing other malignancies. Also in patients who have had a lot of treatment prior to getting to CD19 CAR-T, they also might be at risk for other malignancies, including lymphoma, which would be secondary lymphoma. I am going to walk you through 2 constructs that hopefully will get FDA approved in the near future, and thus, would be very helpful for our community partners to look at. One of them is raptacabtagene autoleucel in patients with relapsed refractory diffuse large B-cell lymphoma. This was a study that was presented by Peter Rydell. So what is raptacabtagene? I'll keep it simple. It's basically a CD19 CAR-T that utilizes something called a T-charge platform. And what this platform does, it preserves T-cell stemness, and thus it makes the CAR persist a little bit more, hoping that the duration of remission is much longer. In addition to that, the manufacturing time is an astounding 2-day manufacturing time. However, the vein-to-vein time is still something that made 60% of patients get bridging therapy on this study. Regardless, this was something that was remarkable with regards to the explored endpoints of complete response rate. It was a heavily pretreated population in this phase 2 study at a median follow-up of 16 months. The primary endpoint of overall response rate at 88% and complete response rate of 62% were met. The 12-month PFS is 48%, and the 12-month overall survival was 83%. With regards to safety, again, as expected, cytopenias were found. CRS was found in 44%. Less than 7% of patients experienced grade 3 or higher CRS, 5% with grade 3 or higher ICANS. There was 1 grade 3 HLH. In terms of the second construct that I would also like to talk about is the CD22-directed CAR T-cell therapy. We are coming into the world where we are now beginning to look at patients who have progressed after CD19 CAR T-cell therapy. These patients, unfortunately, have a very dismal overall survival. So expressing or targeting another antigen that has not been targeted before seems just about the right approach, and this is where firi-cel has been explored. This is some of the initial data with long-term follow-up. Firicaptagene autoleucel, or firi-cel, is a CAR-22, so directed against CD22. It's an autologous CAR-T product. It was a single-center Stanford experience, phase 1 dose escalation study with a primary endpoint of feasibility and safety. About 38 patients, all of them had failed prior CAR T-cell therapy, and so 37 had failed prior CAR T-cell therapy, and 1 did not have CD19 expressed. So these were the 38 patients that were taken to this study. 30% of patients were refractory to last line of treatment. The median line of treatments were 4, and they finally did settle on the RP2D redose of 1 million CARs. And at a median follow-up of nearly 40 months, you can see that the estimated 3-year progression-free survival in patients who had failed prior CD19 CAR-T is 30%. If you look at other data, which has been looked at in post-CAR-T progressors, the 3-year PFS is less than 10%. So I think this is remarkable with regards to its efficacy, and it looks like at the 39.8-month follow-up mark, it is also quite durable. Most common safety issues with related to cytopenias. There were no grade 3 or higher CRS, ICANS, or even HLH that was found. 4 patients did have second primary malignancy. None of them had T-cell lymphomas. However, there was a slow CD4 count recovery, so more patients were dependent on IVIG for a longer period of time. Given how promising this construct appears, a phase 2 open-label multi-center study is currently enrolling. And with that, I'll come to the end of my presentation.
That was really great. And before we get to your cases, I'd like to give the rest of the faculty a chance to throw out any questions to the group and also maybe respond to some of the questions I had from your presentation. I want to start out with Martin and the very end of that presentation, which I was very interested in. These new CAR-T preparations, firi-cel and raptacabtagene. Martin, any comments about these products and where you see them heading?
Yeah, I think the results, also the one referred to that we saw at the ASH meeting recently, is really quite astonishing, particularly in the CD19 CAR-T refractory population. So I was just wondering. Of course, CD19 CAR-Ts, the approved compounds, are pretty well positioned in both second and third line. Are there any plans to challenge the CD19 CAR-Ts in second and or third line by the new products, which may or may not be even more potent than the ones that are registered?
Gilles, any comments about this? Are you aware of any studies comparing this to CD19?
No, I think, it's very challenging to imagine studies using control arm with commercial CAR-Ts these days. I think it's a challenge, and it's unfortunate because I think there may be other ways. Maybe the question that I will ask to Manali, if she has the willingness, is as today, as you mentioned, especially with Lysocell, I don't think any patients is not eligible based on age, and maybe comorbidities may not be that an issue that it used to be. So what are the patients that you cannot bring to CAR-T? Can you develop a little bit on that? I mean, for me, it's mostly patients with really uncontrolled disease progression, very rapid pace of the disease. Any insight on how to manage these patients before CAR-T for community colleagues?
Yeah, I think that's a really important, pertinent question. I do believe a lot of academic centers, for now, it is in the eyes of the beholder. It's very hard for us to not offer CAR T cell therapy. So I have taken a nonagenarian to CAR T cell therapy successfully, who has been very fit with preserved organ function. But to your point, I think there are certain factors that I would absolutely consider. It would be related to patient-related factors, which would be lack of a social caregiver support. It's just so crucial to make sure that they have a caregiver for 24/7. And it is a commitment that we have as an academic site to keep these patients for 30 days. And if we don't have a caregiver, then that's just not going to be possible. There is some data with regards to serving patients in the rural areas versus in the metropolitan areas, and there is a huge disparity there. So I think there is clearly a gap that we need to bridge. So I think that's the patient-related factor. The tumor-related factor is absolutely also important, because sometimes, no matter what you do, as Matt has coined the word of brain to vein and vein to vein time, I think it's just so important, because at the end of the day, when we get that call that we want to send the patient to CAR-T, the first thing we do is get a payer to authorize it. And that in itself takes 2 weeks. And then we get a scheduled patient on apheresis. So that's 4 weeks. And then we get the product manufactured. So clearly it's not something where the tumor is rapidly proliferative. I think that's where bispecifics will potentially have the hugest impact. Whether to use them as bridging or not is definitely an area of further investigation. And then in terms of organ function, there is a lot of anecdotal data, retrospective small cohort data, that you could take patients with COPD, patients even on dialysis, to CD19 CAR T cell therapy. But I think at the end of the day, it's incumbent upon us to make sure that we make these models and build them and replicate them to truly understand which patients will benefit from it. So I think one of the European registries did show that pre-treatment, pre-CAR, if the LDH is elevated, if the extranodal sites are there, and if the TMTV is high, these patients really don't benefit from CD19 CARs. Do I not offer them CD19 CARs? I don't. I think I offer them to all. But having a contingency plan for these patients is very, very crucial.
So before we go into the cases, just to turn to Matt, any thoughts about some of the things that have been brought up? And what's your approach in terms of how much do you try to avoid CD19-based therapy prior to CAR-T?
Yeah, I think Manali hit it right on the head. I think with an access issue that we currently have with CAR T cell, not only in the rural communities, but even in the metro communities, I think the reasons to not getting to CAR are slightly different. And I think that it's on us to continue to show the value of these therapies through an intent to CAR analysis, which often comes, at your own institutional levels. Because right now in 2025, I think the biggest thing is actually half the battle is getting to the CAR T cell, and working with the referring physician to ensure that they're not giving the wrong therapy in the pre-apheresis bridging period of time. And I think we can do better as a field to educate around this. And the way I do it is speak to the patients and the caregivers about there's two different bridgings. There's pre-apheresis bridging and there's post-apheresis bridging. Some have called it different things, but I think as part of the linear journey for the patients is we know know we do not want to give bendamustine in the pre-apheresis period of time. And I think Pola-BR is a very easy and simple regimen that is reached upon by community providers. And to just know that is a reasonable thing to do after you've apheresed an individual, but it certainly can hold us back, or at least perhaps encumber the CAR T cell efficacy on the back end. I think one of the things that we're learning is in the vein to vein time, we're giving a lot of ineffective therapies in this time that are only causing, their ECOG performance status to worsen, but not really getting disease stabilization. I really think that radiation therapy is an important tool that we are underutilizing in the vein to vein period of time. We've shown data at this ASH of just boom boom, which is 2 grade times 2, given in the vein to vein period of time, was very feasible, as well as we showed very good efficacy in an early patient population that's now fully accrued and looking for longer follow-up data at 30 patients. And I hope we can expand that to multiple different sites to show the efficacy. And it's very low toxicity to the patient. And I think there is data to support that maybe this improves actually the toxicity profile on the back end, patients who have been previously radiated.
That's really a fascinating point about the radiation therapy. So let's go on to your first case, Manali. I'm going to ask Martin after she presents this to comment on it.
Okay. So this is a 61-year-old male. He's a jeweler. He had excellent ECOG when he was initially diagnosed. His symptoms at presentation were fatigue, night sweats, shortness of breath. Imaging and biopsy further revealed and staged him as a stage 4 diffuse large B-cell lymphoma, non-GC phenotype. FISH was normal and an IPI of 3. He was initially treated with R-CHOP for 6 cycles and he achieved a CR. 8 months later, he presented with abdominal pain. PET-CT, as you can see, revealed a really bulky abdominal mass with biopsy that was positive for the same phenotype of diffuse large B-cell lymphoma. LDH was elevated to 2 times the upper limit of normal. Fortunately, his blood counts were well preserved. His performance status remained excellent. He did have abdominal pain as the presenting symptom, but fortunately, again, he had robust social support. So after initial consultation, at that point in time, it was decided that based on the existent new SOC, he moved forward with CAR T-cell therapy with Lysocell based on the transform data. 7 days after the consultation, he underwent apheresis. I think this is an aberration, but he was fortunate enough to have a payer that authorized him for CAR and a slot that was available within 7 days of consultation. Post-apheresis, because of the bulk of disease, we considered radiation. However, the patient declined, and then we chose polatuzumab plus rituximab 1 cycle. We decided not to do bendamustine, even though it was in the post-AFI setting, because Pola plus rituximab and Benda was not quite compared to Pola-R, and we have seen good success with just this doublet. Pre-LD, his chemo PET actually showed stable disease, but there was no response to polatuzumab and rituximab. 27 days after apheresis, so now we are a month in, he received LD chemo followed by Lysocell infusion. On day 5, he developed grade 2 CRS, and on day 9, he developed grade 1 ICANS. These were managed per the ASTCT guidelines to complete resolution by day 13. Neutropenia did persist until day 22. However, by day 30, he returned to his primary oncologist. He lived about 5 hours from our center. Day 90 PET-CT, as you can see, showed a Dovil 1 complete metabolic remission, and he is now 2 years out and post-CAR-T, and he remains in a remission. So he did ask me, does that mean I have been cured? And I will open it up to the panel.
So, Martin, any comments about the case? How would you answer the patient?
Well, I would say to the patient that there's never a 100% guarantee, but a very aggressive lymphoma, which on top of being aggressive is primary refractory, you would expect in the vast majority of cases the second relapse or the second failure to be within the first couple of years. So I would say yes. But that's not to say that I wouldn't keep following the patient, because you never know. I think this is a great case of a medium risk patient. And also you just talked about the tumor burden being to some extent predictive of outcome. And it's also predictive of CRS to some extent, both with the CAR-Ts and bispecifics. But this case obviously turned out really well. I have one question for you. So, in a patient like this who is eligible for any CAR-T, I suppose, fit and relatively young, what factors in when you choose between axi-cel and liso-cel in this case?
I honestly think it's a discussion with the patient, because patients are so savvy these days. He knew his data. He came to me knowing exactly that he was going to be offered CD19 CAR. He needed help choosing between axi-cel and liso-cel. I had thought that because he was a non-GC phenotype, if I gave him bridging after apheresis, I think polatuzumab and rituximab would at least yield a stable response, which fortunately it did. But a lot of these things also depended on the fact that he straight away went on to apheresis within a week of getting a consultation. I think that may not have been the case if it was someone else with maybe a little bit of a difficult payer authorization model, in which case I think I may have pivoted to axi-cel just because I need to get the manufacturing done faster. Now, fortunately, in 2024 and beyond, I think even liso-cel manufacturing has improved. It used to be 34 days. Now it's about 23, 24 days. So it's really about choosing one more week. But I think the biggest selling point for this patient was the fact that the toxicity profile was much more appealing. And because he really wanted to go back to work, he decided he did not want to choose axi-cel. So that was why we decided to go with liso-cel.
Matt,
but the stars clearly aligned for him. Yeah.
Yeah,
Sorry.
I agree, Manali. This was a, kind of a dream situation here, especially, a primary refractory patient. I think one of the hints about this was that he had stable disease with POLA-R. I think we're see a lot of struggle in those vein to vein patients that are progressing through. And it's why I, like you, get a pre-CAR T-cell PET CT if I give some vein to vein bridging, if insurance allows, so I can kind of try to predict. Plus, I think when you have high tumor burden like this, I'm walking into the patient and their family, especially, of saying, you're likely going to have CRS. You're likely going to have ICANS. My job, my team's job is to keep it from grade 3, 4 ICANS, right?
Exactly.
That's the length of stay changing event. That is the quality of life changing event. And I do speak with patients and families about people who have ended up in acute rehab facilities for weeks, if not months, especially if they get high grade ICANS. That doesn't necessarily mean that they're going to all be responders either. And so having that PET scan going into CAR T-cell, if you get into the crunch moments, which are days 14 to 20, and they're having kind of that lingering high grade toxicity because of the high tumor metabolic tumor volume going in, that PET scan at that time point, can be incredibly important in discerning, to keep going or to pull back, especially if there's rapid disease progression. But if you don't have that PET scan after your vein to vein bridging, then you're relying upon a lot of times scans, which are 6-8 weeks old. And I caution, even my colleagues, I like to have that pre-CAR T-cell scan to help advise, especially in situations where I think there, regardless of the construct, there's going to be toxicity.
Right.
So why don't we go on to the second case? But first, the question just sort of popped into my head, Gilles. What do we know about responsiveness to CNS disease with CAR-T?
Well, I think the experience comes from the Transcend study, and there were a few patients in this study that received CAR-T and responded well. Some are only leptomeningeal disease, others have both lepto and CNS. Since that, we have seen multiple series, and I think it's interesting to see that despite our concern that potentially these patients may have significant ICANS, the rate of ICANS doesn't seem to be very higher, maybe slightly higher, but not significantly higher than the other patients. Many patients respond, maybe a little bit 10%, 20% less than the other patients. I think what is probably unclear for me is the durability of this response, whether the response are really durable and these patients are cured. There are series showing patients up to 2 years. or whether, we need something else when we do CAR T. But clearly it allows to control the disease. And I think we should really think on how bringing CAR T in patients with either primary CNS lymphoma or secondary CNS lymphoma early on in the management.
Let's go on to the second case, a 68-year-old man, Manali.
So this is a 68-year-old male patient. He was actually homeless to begin with, and he had an excellent performance status. He was diagnosed with stage 3 high-grade B-cell lymphoma, GC phenotype. He was a double hit with an IPI of 4. Of course, our hospital leadership was very kind to sponsor all of this. He was initially treated with dose-adjusted Epoch-R for 6 cycles, followed by high-dose methotrexate as prophylaxis. He achieved a complete remission. Unfortunately, 3 months later, he presented with right lower extremity edema and left lower extremity edema with a humongous thigh swelling, as you can see there, secondary to a bulky thigh mass. This was biopsied and confirmed to be refractory diffuse large B-cell lymphoma, again, double hit phenotype. LDH was elevated to 5 times the upper limit of normal. He was anemic by the time we saw him, hemoglobin of 10.5, and his ECOG had now gone to 2. Fortunately now, he had a robust support system. We also admitted him. A lot of this happened in the hospital. We ended up with getting him authorized for CD19 CAR T cell therapy with axi-cell. Clearly, as you can see on the right thigh here, there was actually a 30 centimeter mass, and we absolutely needed to get something that we knew would guarantee manufacturing, faster manufacturing. So we chose axi-cell. He was 68, but had a good performance status overall. He did undergo radiation therapy to stabilize the mass as bridging therapy. And he did actually end up with a lot of ulcers and sores after radiation, just because of, tumor necrosis. After axi-cell, his post-CAR T course was actually complicated. He experienced high-grade CRS, he experienced high-grade ICANS, and he was in the ICU for 30 days. He also then had a PET scan because we wanted to make sure if he was responding or not. You can see his PET scan down there. The entire 30 centimeter mass had actually disappeared. So he had achieved a complete metabolic remission. But by now, he was profoundly cytopenic. His ferritin was in the thousands. It was 70,000. We had to actually dilute the specimen to get the actual number. His CRP was over 100. And of course, he had a lot of other organ dysfunction. But you can see on the PET that his spleen was really very, very avid. His PET-CT on day 30 showed a complete metabolic remission. However, by IEC-HS criteria, he met the criteria for HLH. So that's when he underwent treatment for HLH, and he actually recovered. He then had a 2-month course in the rehab facility. He was quite committed. Unfortunately, at the 6-month mark, PET-CT showed progression of disease at a very different site. His progression was in the right axilla, and it was about 16 centimeter mass in the right axilla. And at that point, we did have glofitamab approved. So he subsequently was treated with single agent glofitamab, and he achieved a remission. He achieved a remission after the first 3 doses. And when he got there, we knew that after 12 doses, there was probably a high chance he would maintain the CR. So now he's finished 12 doses. He's achieved a complete metabolic remission, and he remains in a CR 6 months after completion of glofitamab. So clearly the big question is he's 68. He's achieved a complete metabolic remission. Now he actually does have insurance. He has a job. He's able to do it all. Is this the right time to take a 68-year-old to an allo transplant, or trust the data that Dr. Hutchings presented at ASH at the 3-year mark with regards to these complete responders? So it's been an evolving conversation. He's not yet committed to doing an allo, so he's currently only on observation.
So, Martin, what a saga. You want to make a movie out of this case. Incredible story. What amazing. So much was put in there with CAR T, too, and you're still with the patient relapsing. What about an allo, Martin?
And so that is a $1 million question, which none of us can really answer at this point because we don't have the data to support either or. I can tell you that with the almost 8 years of experience that we now have with glofitamab from the opening of the early studies, we did, and it's not only me, all the other investigators who worked with the glofitamab in the phase 1 and 2 experience, take quite a few patients to allotransplant in the early years. And with growing confidence in the stability of the remissions, that frequency has dropped. And I don't have the exact numbers, but I can tell you that I have not personally sent a patient in remission after glofitamab to transplant in the last 3 years. And this is not because I think it is not a good idea. I'll show you an example later of a patient that fared very well with a transplant. But the majority of patients remain in CR, as you said, for 2-3 years, a small majority. And, with the potential risks of an allotransplant, even with improved strategies, for the majority of patients, I would choose not to. But you can hear, I'm not very, very strong in my opinion or particularly confident.
So maybe we'll hear more from the rest of you about that thought moving forward. But let's move on, though, and get to the next module here, where Martin is going to talk about bispecific antibodies in diffuse large B cell. So, Martin, could you please take it away?
Yes, absolutely. So, yes, I'll be addressing the bispecific antibodies, CD3, CD20 antibodies, and I will restrict myself to showing data from 2 of these antibodies, the approved ones, that's glofitamab and epcoritamab, but they are not the only CD3, CD20 bispecifics that have been developed in the last 5-10 years. This is a slide showing the most maturely developed ones, and I'm showing you mainly this to tell you that even though they all target CD3 and CD20 on the effector and B cell respectively, there are differences in both production method and structure, and also the binding sites are somewhat different. So epcoritamab uses the ofatumumab binding site on the CD20 external portion of the CD20 protein, whereas glofitamab uses the same binding site as obinutuzumab, and there are also differences in the binding site on the CD3 subportion of the T cell receptor complex. I think the most striking difference probably in the structure between glofitamab and epcoritamab, as well as all the other CD3 CD20s, is what you see at the bottom of this slide, which is the 2-to-1 format structure of glofitamab. So there are 2 binding sites for CD20, 1 for CD3, perhaps explaining a higher affinity of that particular antibody. And they've never been compared head-to-head in patients. There are no randomized studies, and just like the difficulty in randomizing against CAR-T, it's also very tricky to randomize 2 different bispecifics against each other. So we're not very likely to ever see that. So we'll have to make do with what we have. And they are the not randomized studies, but the comparative studies in the preclinical models that you see here. And I think actually being the best comparison that we have, a quite good testament of the somewhat superior potency of epcoritamab and glofitamab in comparison with the other CD3, CD20 bispecifics, as we see that at very low doses, they lead to higher T cell activation and T cell mediated cytotoxicity than the other compounds. So this was the work that had been done leading up to the phase 1 studies. And during the phase 1 studies of these different compounds, it was clear across different histologies, across very different dose levels, that glofitamab and epcoritamab, at least in my eyes, stood out as being the most potent ones, particularly when looking at the aggressive lymphomas. You can see that we saw, again, across different dose levels, response rate exceeding 60% with more than 40% of complete responses. And of course, keep in mind in phase 1 studies, you do very strongly select patients. These are not the average patients in the clinical situation. Phase 1 patients are generally quite fit and good, but still very impressive activity, which led us to the phase 2 studies of glofitamab and epcoritamab, which have led to the approval of these agents in third line and later treatment of large B-cell lymphomas. So beginning with glofitamab, the phase 2 study of that drug looked like this. Fixed duration treatment of 12 cycles, 20-day per cycle. And in the first cycle, there is this step-up dosing, which is used in the management of all the bispecific antibodies in order to mitigate serious cases of cytokine release syndrome. We start with a relatively low priming dose, then a higher intermediate dose, and then in the case of glofitamab, from cycle 2, day 1 and onwards, the full recommended dose of 30 milligrams, which is then given for the remaining 11 cycles. But something special about glofitamab is that before the priming dose, the week before, we give a single flat 1,000 milligram dose of obinutuzumab in order to deplete circulating B cells and also perhaps to reduce tumor burden a little bit. And this is not in order to treat the patient, but in order to mitigate high-risk, high-grade CRS as well. And whether in fact it's necessary, we can't be quite sure because we've never treated a single patient with glofitamab without such B-cell depleting pre-treatment, but we know from preclinical models that the cytokines were not just a storm, but actually a tempest in the models where glofitamab was given without the anti-CD20 pre-treatment. So into this study went patients with large B-cell lymphomas, including transformed folliculars, primary mediastinal and high-grade lymphomas with a good performance status, and like I said, a minimum of 2 prior lines of treatment. Also, a reasonable organ function was needed in order to enter this study. Despite those criteria, you can see that the patients were really quite high risk, quite sick. 1/3 of patients exposed to and failing a prior CAR-T, almost 90% with prior refractoriness, and importantly, 84% with refractoriness to the most recent line of therapy, and almost 60% with primary refractoriness. So quite a sick group of patients, even though only 1/3 exposed to a prior CAR-T. And this is a consequence not only of the timing of the study, which is now a few years back, but also that the majority of patients in this study were treated outside of the US, where at this point CAR-Ts were most maturely developed. So quick look at cytokine release syndrome. You can see that the majority, almost 2/3 of patients in this study experienced some degree of cytokine release syndrome. The vast majority of those no more than grade 1, which is of course monosymptomatic fever, quite easy to manage, and very few patients with cytokine release syndrome of grade 3 or higher. Almost no cases of ICANS, and perhaps that is a consequence of the CD20 rather than CD19 target. But we do see occasional ICANS-like neurological side effects, which of course have to be managed, and in the majority of cases are quite easily managed and transient. You can see that on the right that the majority of cases of cytokine release syndrome happen after the priming dose of 2.5 milligram, but we also see cytokine release syndrome later during the step-up dosing, but very rarely beyond cycle 2. What about responses? These are the most recently updated data, and of course the response rates don't change so much with extended follow-up. So we still see 52% of overall response, including 40% of patients experiencing a complete response, and the median duration of such complete response at this point, this changes from analysis to analysis, is 30 months, with 56% of patients reaching a CR, still in remission, maintaining the complete response at 24 months of follow-up. And this is actually interesting to look at. These are the landmark analyses of progression-free and overall survival, where the landmark is set at the end of treatment, and what the progression-free and overall survival curves show you the survival of patients according to response categories. And why is this important? Is this just to cheat and make the results look more pretty? No, it's really important because this is an fixed duration treatment. So when patients who have responded really well and they have limited side effects, they stop treatment, and they are not all happy about this. Some of them will say, why do I have to stop treatment? I don't have any side effects. Is this safe? And then it's really nice to have the landmark analyses showing you that more than half of the patients, even 2 years after stopping treatment with no intervening subsequent treatment, are still alive and progression-free at that point, leading to an overall survival at 2 years for those patients reaching a complete response of 77%. So switching over to epcoritamab, the phase 2 study of that drug was in many ways quite similar to the study of glofitamab, very comparable in an exclusion criteria, almost exactly the same group of patients studied. But the design was slightly different. That's because epcoritamab is given in a slightly different fashion. There is no obinutuzumab or other anti-CD20 pretreatment, so the patients start directly with epcoritamab, and also epcoritamab is given subcutaneously, unlike glofitamab, which is given as an IV infusion. Also, the step-up regimen looks quite different. I showed you that glofitamab priming dose is 2.5 milligram, which is really a biologically active dose where we see tumor reductions from day one. Epcoritamab priming dose is 160 micrograms, so 30-fold lower. The intermediate dose given after 1 week is 800 micrograms, so still in the microgram range. And then from cycle 1, day 15 and onwards, the full dose of 48 milligrams, so 48,000 micrograms is given, and that is given until progression. In the beginning, every week, then after 3 months, every 2 weeks, and then after 9 months, every 4 weeks. But it's a treatment given until progression. Look at the baseline characteristics. It's almost a copy of the slide that I showed you from the glofitamab study. Almost the same number of patients, 54 in glofitamab, and here 157. And if you look at the risk profile of this patient group, more or less the same as in the glofitamab study, with just over 1/3 of patients being exposed to and failing a prior CAR T, the vast majority with refractoriness to the most recent treatment line, and again around 60% of patients with primary refractory disease. So more or less the same risk profile as in the glofitamab study. Also, in the context of epcoritamab, a small majority of patients experience cytokine release syndrome, very rarely beyond grade 2, but the dynamics are a little bit different than from glofitamab. You can see that the majority of cases of cytokine release syndrome happen not after the priming or the intermediate dose of epcoritamab, but after the first full dose of epcoritamab given after 2 weeks. And you can speculate actually whether, in fact, the priming dose and perhaps the intermediate dose of epcoritamab more or less functions in the same way as the obinutuzumab pretreatment functions in the context of glofitamab, primarily to deplete B cells. I did my own private studies of this, doing a lymphocyte differential count after the priming dose and immediately before the intermediate dose, and we see full depletion of the B cells at this point, even though very rarely there is any actual clinical response to be seen at that early point in time. So, slightly higher overall response rates, even though, of course, that's an indirect comparison. 59% of patients with responses, including in the most recent analysis, 41% with complete responses. And the durability of these complete responses, 36 months median, which is, of course, numerically slightly higher than the median duration of complete response to glofitamab, which was 30 months. But I think these results are really very comparable. And also, according to different histologies, there seems to be very little difference, as you can see. So we've known for some time, because of the chronology of things, that the bispecific antibodies work reasonably well also in patients failing a prior CAR T, and Dr. Kamdar showed a very good example of this, obviously. Do we also know that the opposite is true? Well, until recently, no, that wasn't the case. So that was an important argument for giving CAR Ts prior to bispecifics. But relatively recent data that came out last year from the excellent French database effort called the Discard database show that actually the opposite is also the truth. So in other words, patients who had been given bispecifics and failing bispecifics, and all of these patients, of course, treated in clinical studies and then subsequently exposed to a CD19 CAR T, seemed to respond as well to that CAR T as they would be expected to without previous exposure to a bispecific. So for the last couple of minutes, I'll just mention one of many very interesting combination studies involving the CD3, CD20 bispecifics. And this is the STARGLOW study, which was presented and published last year. So this was a randomized phase 3 study in transplant ineligible patients with relapsed refractory large B-cell lymphomas with one or more prior lines of therapy and stratified according to numbers of prior lines of therapy. It was a 2-to-1 randomization with 2 out of 3 patients randomized to an arm where patients were treated with GemOx plus glofitamab, and the remaining 1/3 of patients had the standard treatment of R-GemOx, if you can call that a standard treatment, all given for 6 cycles and for 8 cycles, and glofitamab in the experimental arm administered for an additional 4 cycles, so reaching the registered 12 cycles of glofitamab. The primary endpoint for this study was overall survival, quite a bold endpoint in this setting, but nevertheless, the study was convincingly positive. So both when looking at the primary endpoint and also the important secondary endpoint of progression-free survival, you can see pretty obvious and also clinically meaningful advantage in favor of the experimental arm. And actually this despite the fact that there was a large overrepresentation of fatal COVID events in the experimental arm compared with the standard arm of 7 to 0 difference. And nevertheless, we see this striking benefit when looking at overall survival. So that leads me to the end of this little talk, where I hope I have not convinced you, but consolidated your conviction that the bispecifics are very active in their anti-tumor activity. Glofitamab is given IV with a steep step-up dose for a fixed duration of time. Epcoritamab is given subcutaneously with a slow step-up dosing and until progression or unacceptable toxicity. And these are the most important differences between two drugs that otherwise work in very similar ways and have outcome data and toxicity data that are strikingly similar. Data from the phase 2 studies of these two drugs in patients with relapsed refractory large B-cell lymphomas and a minimum of 2 prior lines of treatment are quite similar. Response rates between 50 and 60% and complete response rates around 40%, of which more than 50% are durable beyond 2 years. Median duration 30 of complete responses, like I said, 30 months for glofitamab, 36 months for epcoritamab. I wouldn't put too much emphasis on that difference because, of course, this changes from analysis to analysis, and it'll be interesting to see data from subsequent analyses with even longer study follow-up than the ones we've seen so far. I haven't talked so much about toxicity to not overlap too much, but I repeat that we see very rarely cytokine release syndrome beyond grade 2 and even more rarely CNS-related toxicity, be it something that we can call ICANS or not. One very interesting feature about the bispecifics in my eyes is that the toxicity profile and mechanism of action make these drugs really ideal combination partners. So I personally do not believe that the bispecifics really meant to be living on their own. I think they should be combined intelligently, not necessarily with chemotherapy like we do in the STARGLOW study, but also with other novel agents and preferably perhaps co-stimulatory antibodies to introduce the co-stim signals which have proven so effective in the context of the CAR-Ts. So with that, I finish my talk.
So that was great, and we'll get to your cases in a second. But again, I want to give the rest of the faculty a chance to make some comments or bring up any questions. I'll start with Manali, and also maybe you can address, Manali, the issue of sequencing of bispecifics and CAR-T and whether that you individualize that based on what the situation is.
Yeah. So to answer your question, I think right now the question is in the third line setting in terms of whether we choose bispecs first or CD19 CARs first. I think I shoot for a cure, and we do have a 5-year follow-up in the third line setting with CD19 CARs. So I offer a curative strategy first, but I think it's just a function of getting more follow-up on the bispecs. But a couple of questions that, I definitely want to also ask Dr. Hutchings is with regards to bispecs, and that definitely is something I choose when it comes to sequencing, is target antigen expression as well as CNS penetration. So if I have a patient who does not actually have CD20 positivity or a patient who has systemic and CNS involvement, I typically refrain from a bispec. Clearly, it's off the shelf. It's definitely easier on the patient. A CD19 CAR is one and done, but very high upfront commitment. Less toxicity with the bispec, slightly more toxicity, but manageable toxicity with CD19s. But I kind of struggle with CD20 negative tumors after CD19 CARs or patients who could be eligible in the third line setting with a CD20 BiTE. Do you offer these agents to CD20 negative patients?
No, that's the short answer. So while there have been analyses across various programs showing little relationship between the magnitude of CD20 expression and the benefit for the patients that lack CD20 expression do not respond. There might be a few exceptions for that rule, but that's the general observation. I've never seen a CD20 negative patient respond. And on the contrary, loss of CD20 seems to be a mechanism of resistance. So we see in many cases patients who respond to glofitamab or to epcoritamab then later relapse, typically quite local relapses, and then when you biopsy, you see a loss of CD20 in the site of progression.
And do you offer these in patients who have CNS and systemic disease?
No, we cannot do that because so far, the approval of glofitamab and epcoritamab are quite recent. They are not approved as such for CNS disease, and none of the studies performed with neither glofitamab nor epcoritamab so far have allowed for inclusion of patients with CNS lymphoma. I have treated a single patient with epcoritamab who had a CNS lymphoma. We didn't know that because brain scan wasn't mandatory, and there were clear signs of clinical activity. He got into generalized convulsions already after the intermediate dose of epco, but that is an indication rather than proof of efficacy. I would be quite confident that these drugs would work in CNS lymphoma, just like you've shown with the CAR-Ts. So it's a bit of a shame that CNS lymphomas are always left on the platform long after the train has left.
And I think there was a publication from the City of Hope, which I know you know Dr. Kamdar, of that experience. And I kind of look at it as I wouldn't probably hold back glofitamab if I knew they had systemic and concurrent CNS disease, with a discussion, right? And they have had to probably try other things in that realm, but we have a tough time for some reason, as Dr. Hutchings was pointing out, of getting trials which allow secondary CNS disease and systemic disease. For some reason, they get excluded all the time. And so we're stuck with these real world experiences with these novel therapies like Glofit, and trying them in this population. And then fortunately, there's a case series that helps give us some clinical confidence in that situation.
So Martin actually prepared 4 cases. I don't know if we're going to be able to get through all of them, but Gilles, why don't you respond to this case first? Martin, you have a 42-year-old man. What happened with him?
Yeah, so this, I'm showing you him because it has an unusually long follow-up. He was treated during the dose escalation phase part of the phase 1 study of glofitamab, and he had given a dose which is only a fraction of what is now the 30 milligram approved dose. And he presented with quite rapidly progressive disease refractory to 2 prior lines of treatment, including autologous transplant, and responded very dramatically, actually. During the first night after the priming dose, he had tumor flare giving severe abdominal pain. You can see he has a retroperitoneal tumor and also a supraclavicular tumor, which during the first night of his treatment compressed his sympathicus enough to give him a very impressive Horner syndrome that was shown to all medical students in the hospital the following weeks. But he recovered completely from these phenomena and went into first a good PR and later perhaps a CR, but he remained being a little bit PET positive in his left supraclav region. So at the end of his 8 cycles of treatment, which was the duration at that point during the study, we gave him a little bit of consolidation radiotherapy, and he remains in CR after that radiotherapy consolidation. So I'm showing you him because he's the first patient that in my hands, in my care, that I can reasonably comfortably say was cured with glofitamab for an aggressive lymphoma.
Yeah, 5 years of CR. Gilles, any questions or comments about this case? Can you talk also, Gilles, about your experience with tumor flare?
Yeah. So maybe that's what I was going to say. That there are 3 lessons here. The first one is a rapid response, and as Martin alluded to, there are some tumor flares, and I think the kinetic of the tumor flare still is not very well determined. As you said in your case, it's within 24 hours or 48 hours. I think we have seen some patients, and sometimes it's a little bit difficult, to assess, that may have a little bit delayed of tumor flare, like day 8, day 10. Probably not after, day 20 or something like that. I haven't heard about that. But I think during the first cycle, you have to be careful not to say the patient is progressing. This can be flare if you say the cycle is 21 days or 28 days for EPCOR. So that's the first lesson. The second lesson is that, as you show here, the response is very rapid. And I think we probably start to know that if you evaluate your patient at 6-8 weeks of treatment, you identify the responders and you identify the non-responders. There are reports that some patients respond late, but I think the vast majority of patients respond early. And the third lesson, and I'm curious to hear back from you about that, Martin, is, we have evaluating patients with PET in the age of chemotherapy plus rituximab, and we are now facing many patients, with either bispecific or CAR-T who have this residual uptake with PET. And, we have seen a patient that really insisted to have a biopsy twice, actually, and twice it didn't show any tumor, but just, some inflammatory background. This is well known with CAR, and CAR is a living drug, so you can say, the response can be delayed and things like that. Do you have any experience with bispecific of patients keeping positive PET, like a very good PR, and, continuing to extinguish over time or being stable? I think it's probably an unknown question with this immune-based therapy.
I agree completely, first of all, Gilles, with your take on tumor flare. I think particularly in the context of glofitamab, it's a very common phenomenon which should not be confused with early progression. About PET, I think what we need, we have a job to do in the lymphoma and PET community, and that is to better define Deauville score 4. Because a Deauville score of 5 that lingers on during treatment is not a good sign. Most of these patients, in my experience and in my understanding of the data, will fail eventually, and most of them quite rapidly during treatment rather than after 12 cycles. But I think we all have experience with patients who are in a partial response and either have only faint Deauville 4 uptake and then do quite well even after stopping treatment, or who late during treatment go from partial to complete response. And in my experience, the ones that have a partial response maybe after 2 months and 4 months of treatment and later get into a CR and go into long-term remission, they are the ones with a weak Deauville 4 that we should probably define differently in the future. But that's work ahead.
So, Matt, you had a question. Also, maybe you can answer my question of, is there a correlation between tumor flare and benefit from treatment, Matt?
Yeah, I'm not aware of any benefit of kind of known tumor flare nor a definition. You just kind of know it when you see it, or you hope you're seeing tumor flare and not tumor progression. And sometimes you figure that out within weeks in large cell lymphoma from that standpoint. I agree with Martin. You call it very deep PR. I was like, let's take a page out of myeloma and call it very good partial remission. We know it when we see it. And it kind of brings me back to your case that you had done. And one of the things that I think is, we've not well established is the utilization of radiation. I'm not a radiation oncologist, but I am in favor of using radiation here. And you did in this case, especially after CAR T cell, if you have bulky disease. I always tell the patient, we're going to burn the core, even if you get into a CR. Here it appears you used radiation into what was a bulky lesion in CR and burnt it, kind of at the end of glofitamab. I'm not aware of a lot of data, around that. I would have probably done and had the same discussion clinically. But I think it is something that's kind of missing a little bit in our cellular therapy literature.
Interestingly, this patient, if he was in a clinical trial, he was probably a progressive patient because you treated him while he's in CR long term.
Interesting. So, Martin, let's hear about your 81-year-old woman. And Manali, you can respond to this case after he presents it.
You're not supposed to have favorites, right? But she is a favorite of mine, and she's not 81 now. She was 81 in 2017, but she's still going strong. She's almost 88, and she's absolutely fit. She was for a while the world record holder of duration of epcoritamab treatment, which is not necessarily a good thing. But I did stop her treatment after, I think, 4.5 years of treatment with epcoritamab. But before that, she'd gone very rapidly into a CR after she had failed 3 prior chemotherapy lines of treatment, as you can see, and she never really had any side effects. She had a little bit of monosymptomatic fever during her step-up dosing of epcoritamab, but other than that, no side effects. She had the expected lymphocytopenia and also some degree of hypogammaglobulinemia, and it wasn't until she got a COVID infection in the early summer of 2023 that she couldn't clear that we decided to finally stop that treatment, which probably had cured her already a few months earlier. My best guess would be that she received a couple of years of unnecessary epcoritamab treatment. And I'm just really, really thankful that she finally recovered from the COVID infection and now is doing really, really well. But I think she's a good example. Not all patients respond so well and so durably to bispecifics as these 2 cases, but she's a good example of one of the consequences of long-term B-cell depletion that we see. And not all patients have recovered so well from COVID infections at her age after heavy exposure to bispecifics. There have been a lot of fatal cases, so this is an important consideration.
So, Manali, before you comment, just back to you, Martin. Can you talk a little bit about what happened with the COVID, what kind of symptoms she had, how long it took to clear, and did she have the vaccine?
So she had the vaccine. So we had a 99.6% vaccine coverage in my country, which probably was really good for our patients on the bispecific. But I think perhaps more importantly, you can see she had her COVID in 2023, and the strands of COVID that were prevalent in recent years, they haven't been quite so serious as the ones we saw in 2020 and 2021. So her symptoms were more or less those of a mild cold. So she had dry cough, she had sinusitis, but still going on for quite a long time, and also a fluctuating fever, which at her age, 85 at that point, could be enough to reduce her quality of life significantly. And she did lose 5 or 6 kilos of weight over that summer. She cleared her PCR completely, I believe, in October. So that was after almost 6 months, and she was symptomatic until the late summer.
So, Manali, any comments or questions about this case?
Yeah, I think case for time-limited treatment, clearly because of the long-term hypogammaglobulinemia that these patients unfortunately have to endure. These are excellent treatments, but really we have to do a better job at, saying this is what may be needed to get you to a cure. My question to you, Martin, is, majority of these patients who do get CD20 bites, they may have been treated with CD19 CARs. As a result, they are definitely profoundly B-cell aplastic, hypogammaglobulinemic. So for patients who go through CD20 bites, whether you put them on time-limited or indefinite treatment based on which bite you choose, do you preemptively give them IVIG like we do for CD19 CARs if their IgG goes under a certain threshold at your site?
So not preemptively, but and we have to some extent follow institutional guidelines for IVIG because it's expensive and I work in a socialized healthcare system. But my threshold for giving immunoglobulins is very low. So I would say that any patient where the IgG is below 5 or 6, and they all are, with repeated infections, and when I say repeated, I mean more than 2 in a few months, I will substitute. And they generally stay on that substitution for at least a couple of years because that's the time it takes to recover or to begin to recover. And for any patient with an IgG of less than, say, 3.5, I try to find an excuse to substitute them. And it's most of the time not very difficult. I live in a cold Scandinavian country. We all have colds most of the time.
Any insight, Martin, regarding the sequencing of the bispecific use and the IgIV? Do you use them in same days? If you have a prolonged treatment, do you alternate?
No, we don't have any schedule for this, and I can tell you a really stupid and practical reason for that. We give our IVIG and our bispecifics in 2 different sections of the department, so there's not a big streamlining of that. But I don't know of any data to support either or, to be honest. So it's pretty coincidental what we do.
If I'm allowed, I think what pointed to in the previous case and maybe in one of the following is we should not underestimate, and this discussion rely on that, the risk of infections of our patient and bispecifics. And, we evaluated that recently with colleagues, and it's a risk that is quite significant. It's one of the cause of death of our patients receiving bispecifics. So really paying attention to that in terms of antibiotic prophylaxis, in terms of monitoring, in terms of IgIV supplementation. These are, vulnerable patients that have received already chemo, that have received potentially CAR T, that have received other agents, and we should really be meaningful of the infectious risk, infectious vulnerability, and manage them adequately with both prophylactic and interventional measures.
And also to add to that, I completely agree, but to add to that, let's not forget the neutropenia, which happens with the bispecifics. It's not all patients. I don't know. It's around 15-20% of patients have some degree of long-lasting neutropenia and need repeated GCSF. And, like you said, they are heavily pretreated with T and B-cell depleting agents already for several treatment lines, most of them. So, we give a lot of prophylactic antibiotics as well.
All right, let's see if we can squeeze in one more case and maybe get Matt to respond to it. Can you tell us about the 69-year-old man?
Yeah, so he's another instructive example, I believe. So he had a transformed follicular lymphoma, 3 prior lines of treatment, to which he'd been refractory to the most recent of the 2 lines. He did respond for a few years to his initial R-CHOP. Mild cytokine release syndrome, despite what you can see is a really heavy tumor burden at onset, went into first a PR, which is what you see on the right side of this slide. There is a little PET positive lymph node in the retroperitoneum if you squint and your screen is good. But that turned into a CR at the next PET CT scan, and he stayed in CR until the end of treatment, and he stayed in CR in that remission for 2 years. at which point, unfortunately, he developed an MDS, which very quickly transformed into an AML, which was completely treatment refractory and killed him in a few months' time. And I just think this case is instructive, not only to teach us that this treatment can be effective in chemorefractory patients, but perhaps also the other way around. We should learn to not give so much chemotherapy to patients who do not respond very well, because it's not only the time and the lack of response, it's also all the bad consequences of the chemotherapy. And of course, in this case, serious consequences, which was the MDS.
So, Matt, any comments or questions?
Yeah, no, I think that this just shows the power of this class of drug. And I agree. Manali made a comment earlier about we're just starting to learn about CHIP and CCUS, and, a lot of these mutations, we don't really know what to do with them. And, in this case, and I think we are seeing a transition in the field with a lot of these therapies coming earlier. And maybe we're at a point now with some of the efficacy of these that we can start to pare down the doses of our classical chemotherapies, not unlike what was done in Hodgkin's lymphoma. But I think we're going to see in, the Sky Glow as well as EPCO, R-CHOP, if those are positive trials, and I know we're supposed to be talking about relapsed refractory, but if those are positive trials, those curves are going to be astronomically high. Right, to the point where it would start to look like Hodgkin's curves. And then we start to ask, what's the weakest link of all of those chemotherapy drugs? And it's not going to be glofitamab or epcoritamab, right? It's going to be things like vincristine or the dose of cyclophosphamide. And so we have an opportunity here to start to, whittle away at the chemotherapy classical backbone.
Gilles is going to talk about selection and sequencing of other therapies for relapsed diffuse large B-cell.
Thank you. And I try to navigate through other agents that are available in this field or have been made available. So basically what we're addressing here, and this is a schema that we built several years ago and probably is not exactly reflecting the current situation with CAR T-cell. But we do know that some patients are not eligible for autologous stem cell transplant. They are not candidate for CAR T therapy, either because of the disease space, either because of the lack of care support, all the reasons we discussed, or they have failed these therapies and they are willing to get other therapies. And bispecific have some constraints, including the management of these patients. And we have other agents here that I would like to discuss very briefly. The first one is a combination of polatuzumab vedotin added to bendamustine rituximab. You know that polatuzumab vedotin is an antibody conjugate. You are all familiar with this family of drugs. It's a cytotoxic directed agent. In this trial, where bendamustine rituximab was the control group of phase 2 randomized trial, this ADC was added to bendamustine rituximab in relapsed refractory DLBCL. As you can see, and this is shown on the blue bar, the response rate was low in terms of overall response rates with bendamustine rituximab and significantly improved with the addition of polatuzumab vedotin. And that's a trial that basically led to the approval of this drug in the relapsed refractory setting. You can see the progression-free survival curve and the overall survival curve, which was quite a surprising result, I will say, for a phase 2 trial with only 40% in each arm. Several studies have already confirmed that, and this is an extension study with more than 100 patients. You see on the right of this graph, you can see 100 patients. The median progression-free survival was 6.6 months. Median overall survival was 12.5 months. If we dive a little bit more into who are the patients who respond to Pola-BR, we do know that based on this data, obviously the outcome is better if this is using second line of therapy, and these patients were not refractory to their last line of therapy. This is, I will say, not very surprising. We are dealing here with cytotoxic agent, a combination of cytotoxic agent plus rituximab. And, when you are chemorefractory to R-CHOP, I will say it's unlikely that you will respond to other cytotoxic agent, including an ADC with MMAE. There have been some real-world data presented, and it raised also the question of when do we use this regimen. I think the experience of using bendamustine rituximab and polatuzumab in the post-CAR T setting has been really poor, and you see here a curve with a very low median PFS. We already discussed the role of this combination prior CAR-T. I think we have the consensus now to usually avoid bendamustine in any patients that will be a candidate to CAR-T. So really, we should avoid that because of the potential impairment of T cell function. Whether it's true for patients that are candidate for bispecific antibody or not, we don't know. But then, as Manali alluded to in her presentation, polatuzumab vedotin alone or in combination with rituximab remain a useful agent. I will mention that the polar BR toxicity are present, and this is a case of infections. And as you can see in these phase 2 trials, there was combined with the extension phase, there was about 20% of grade 3-4 infections, and half of the patients have neuropathy, hopefully only grade 1-2, but this raises question. And obviously, there are several questions now regarding polar BR in 2025. So first of all, is bendamustine really useful in this regimen? I mentioned that. Is it impairing CAR-T? I think we believe so. Bispecific, we don't know. I think we've used polatuzumab vedotin in first-line setting based on the POLARIX data and use POLAR-CHIP. I don't think we will reuse polatuzumab vedotin except maybe 1 or 2 cycles for bridging potentially, but at least not 6 cycles. And whether it's efficient in patients with different subtype of DLBCL remains a discussion that is open. So let's move to a second combination that has been approved in patients in the second-line setting, actually, which was a tafasitamab lenalidomide combination. Here we are approaching an immunological based treatment with a naked antibody against CD19 and lenalidomide that you all know and use in both myeloma and lymphoma. What was interesting in this study was an overall response rate that was high for this population of patients with this combination of 60% and a CR rate of 42%. And we saw already from the first analysis that the patients that achieve a complete response to this treatment had a prolonged complete response. And this was true with the initial publication. And when we look at the side effects, this regimen was rather well tolerated. During the first years, this is a regimen where during the first year, you have the combination of lenalidomide and tafasitamab, and you extend and prolong tafasitamab as a single agent later. During the first year of this combination, the side effects are really the reflection of the classical side effect we see with lenalidomide, including neutropenia, anemia, some heme toxicity, rashes, or GI effect. When you continue with tafasitamab alone, the frequency, severity of side effects is diminished. So as I said, with 3 years follow-up, we see the same kind of curve with the duration of response. And this was still true with 5 years of follow-up. There are, however, questions that were raised regarding this trial, which was the fact that primary refractory patients who failed R-CHOP early on, were not accrued in this trial. And this was maybe a highly selected population that was accrued in this trial. In order to answer that, there were a couple of studies that were done, and maybe I come back to that later. The study that we performed was gathering data from academic centers in the US and looking at the CR rate, which was much lower, and the PFS that was much lower. I will say that at the same time, other publications have been reported gathering data for community centers in the US and showing probably better results. I actually missed the slide where the response rate of this report in the recent ASH meeting was down, but the overall response rate was more in the 60-70%. So reflecting what was reported in the phase pivotal trial, phase 2 pivotal trial, the CR rate was still lower in the really 20%. And again, a benefit for patients who receive this combination in second line of therapy. I think there is another message here, which is how long should we continue with tafasitamab single agent? It's a discussion we already had with epcoritamab and bispecific antibody. But was this curve shown when we published the 5 years data of this study? In some of the patients stopped tafasitamab, and if they were in CR, most of them maintained in CR. So I think, it's probably likely, and I think many of us will believe that in patients with diffuse large B-cell lymphoma, when you have a sustained complete remission that lasts several months, 1 year, or even more than 1 year's prolongation of treatment with these drugs may not be necessary. What's the efficacy of this combination in patients what are primary refractory, early failure post-CAR. I still believe this is not a good indication for patients, and I prefer to use this regimen for patients with late failure or have had a good interval-free regimen, because we do see patients doing well. How long should tafasitamab maintenance be pursued? I believe that when the patient is in complete remission from 1 year or so, we should stop it. How do we sequence this regimen with CAR T therapy remains unknown. We were all afraid when using the CD19-directed drug before CAR T that eventually the expression of CD19 would disappear. I don't think we have really observed that. What happens, and that has been clear, is that there is a masking of the CD19 antigen by tafasitamab that can last a couple of weeks. But if you have a washout period, probably there is no impairment of CAR T. And there are even experimental data published by the group at Mayo suggesting that there may be a benefit. So an open question. And finally, the reasonably low toxicity of this regimen make it also a possible combination with different agents, including bispecific antibody targeting CD20, and you will have then a target of both CD20 and CD19, and several trials in this area are being made. The final drug that I will discuss briefly is loncastuximab, which is another ADC, another antibody drug conjugate, interestingly with a quite different payload, which is more an intercalating agent rather than a tubulin inhibitor. So loncastuximab was developed in phase 2 study, and LOTIS-2 led to the approval of this drug. And as you can see, in patients that were quite refractory, I will say, mostly third-line patients, the overall response rate is quite reasonable. Half of the patients respond, and a quarter of the patient had a partial response. If you look at the median PFS, it was only of 5 months. But remember, these are third-line patients, and in the third-line setting, even CAR-T have a 5 months PFS, median PFS. And if patients achieve a duration of response, achieve a complete response, you can see on the curve on the bottom that the duration of response was sustained. In terms of toxicity, this is a toxicity that is a little bit different from other drugs. You have some heme toxicity, including thrombocytopenia, in a significant number of patients. You have elevation of liver enzyme, particularly GGT, but I think it's asymptomatic and not worrisome. What you have also described on the bottom of this table is some patient having peripheral edema, fluid overload, and a couple of my colleagues experienced that and had to interrupt treatment for this patient. And eventually, low dose of diuretics can prevent that, but this has to be managed carefully for patients with impaired cardiac function. So the updated results were published recently, and again, you can see on the blue curve on the top of the PFS that if you look at patients with complete response, the complete response is prolonged. However, maybe a little caveat here is that you can see on the right in the swimmer plot that a few of the patients actually were consolidated with transplant. So what's the real number of patients that have achieved a CR and maintain a CR with only these agents remains to be determined. So the question regarding this agent, in conclusion, how to sequence lonca-T with other agents, I think this is unclear. Again, before CAR-T, I think there haven't been shown any impairment of CAR-T activity, but this is, limited series of patients. Should responders receive autologous stem cell transplant, potentially CAR-T? How to manage the toxicities? And again, here also there are some ongoing studies combining lonca-T with different agents, including bispecific antibody. So I think the advantage of this drug is, again, targeting a different antigen, not necessarily impairing CAR-T. Also a drug that has allowed to achieve a complete response in some patients. So a good compound to keep in the armamentarium, as with for polatuzumab vedotin and tafasitamab and lenalidomide. And ongoing trials are still being performed in this field, despite the fact that it's a crowded field. There is a loncastuximab, rituximab versus rituximab chemotherapy in the relapsed setting, so something maybe parallel to STARGLO. We'll see the results. We have other studies that are confirmatory studies with tafasitamab, lenalidomide, and we presented some result of polatuzumab with rice in the pre-transplant setting, showing very high CR rate. But again, the number of patients that are eligible for transplant those days has tended to diminish, but it's an interesting salvage regimen if you want to put your patient in complete response before an autologous stem cell transplant. Happy to discuss that and answer any questions.
So Manali, any questions or any comments or any thoughts, any teaching points? Because now we're starting to get into an arena that involves the general medical oncologist community a lot more. Anything you want to say about this?
Yeah, I think, amazing presentation. I think in the academic center, I can say a lot of these agents are used in the post-CAR T or post-CD20 bispec setting. But then there are times that patients are unable to get access to these drugs. And I do believe that these drugs come in very handy. But my question, I think, to Dr. Salles is, the CD19 expression in terms of the patient having the opportunity to get to CAR later. If you were to choose between Tafalen versus Lonca-T, Lonca-T is a CD19 ADC, Tafa is a CD19 antibody. Would you hesitate to use one agent over the other? Will that restrict a patient's ability to get to CD19 CAR in the future?
Well, as I said, there are reports showing that the activity of CD19 CAR is preserved. There haven't been reports with any of both this agent of mutation of CD19 or really complete loss, prolonged loss of expression, like we see with, patients treated with CAR. I think it's a question probably of the intensity of the activity of this drug. As we know, and we may discuss that later, there are CD19, CD3 bispecific antibodies being developed, and we like to see what happens here. But at this time, I have, moderate concern about using, I should not say no concern, but very moderate concern about using these drugs. As I said, if I use tafasitamab, or if the patient has been exposed to tafasitamab, clearly we need a washout period, but this is a washout period of basically manufacturing of the CAR. So you should basically do your leukapheresis and find something else for the bridging. That's fine. For Lonca-T, I don't think this is a real issue, but again, you keep that in mind and we'll see what it goes. I will say, like you, we are very, very rarely using this agent before CAR-T or even before bispecifics, but they're here to help. And eventually, especially for patients who are not candidate for this kind of therapy, access, caregiver support, preference of the patient, and all these kind of things.
And I did want to bring up just the fact that maybe I'm in Colorado and, a lot of sun here, but in patients who do get Lonca-T, they can sometimes have very severe photosensitivity. So I think for our community partners, it would be really important to just highlight that they should really be protected when they go out in the sun if they get started on Lonca-T.
That's a really great point. Matt, anything you want to add or any questions you want to bring up?
Yeah, I think one point, regardless if you're a mile up like you are in Denver or at the seafloor like in Omaha, I agree, sun protection. But the other thing that's important about Lonca-T is I think that this is an internist drug. You have to go back and use the physical exam skills and understand that early peripheral edema should lead to some implementation of diuretics, particularly spironolactone. And when I speak to Lonca-T, I call it Lonca-T Dex because I believe that that's how important the dexamethasone the day before, the day of, and the day after is in mitigating the effusion aspect of this. I think you'll never see another phase 1 trial larger than the phase 2 trial, and that was Lonca-T. That shows you how long it took to find the right dose and the right schedule of this very active, target, as well as with the pyrrolobenzodiazepine warhead. But that's why I call it Lonca-T Dex in that regard.
It's a great point. Okay, well, let's go through a couple of cases. And Martin, maybe you can respond to this first case of an 82-year-old woman. What happened with her, Gilles?
Well, this was a woman that was referred to me about 3 years ago. She was a follicular lymphoma history that was treated in 2001 with R-CHOP, and she obtained a CR. During that time, after her treatment, she has coronary artery disease, she had mild renal impairment, and she had an anemia which was documented as an MDS with ring sideroblast. I mean, very well tolerated. Her hemoglobin was in the 10, 11, and never received treatment. Unfortunately for her, and as you can see, almost 20 years after the treatment of her follicular lymphoma, she had a new biopsy on the lymph node showing a DLBCL, which was diagnosed as transform FL. She was treated in another place. She received 5 cycles of polatuzumab, bendamustine, rituximab, which were interrupted because of fatigue, anemia, and neuropathy, and she only achieved a PR. And then when referred to us in January 2022, a new biopsy confirmed DLBCL, and we discussed the different options, including CD19 CAR, tafalen, loncastuximab or clinical trial. We didn't have a bispecific trial open at that time for her, or she may not have been eligible, which is another issue for this patient with, already several morbidities and a story of transformed disease. And basically, we were proposing her to start on tafalen, and she started tafalen in March 2022. Given her kidney function, we decreased the dose of lenalidomide, and that's a key message when you use this regimen. We actually had to interrupt lenalidomide at cycle 2 due to a creatinine clearance drop, and we resume at even a lower dose of 5 milligrams. But as you can see, almost 3 months after, 2.5 months after starting her treatment, she had a very good partial response to this regimen. We continued then tafalen, and 3 months later, she was in CR. There was nothing still visible, and then we continued the treatment. Unfortunately, the anemia continued to develop, and we had to interrupt len, and she ended up developing COVID in December 2022. We discontinued TAFA, and unfortunately, she had complication of this COVID. Again, she was an old woman with several comorbidities, and she passed away from this complication. I will say at that time, she has no evidence of progression of disease, but again, the efficacy of this drug in selected patients can be high. It can be prolonged. We have to equilibrate and manipulate the dose of lenalidomide, and we have to be mindful of the rate of infections in these patients.
Martin, any comments on the case or any questions you'd like to hear discussed?
Oh, I think it's an impressive story. I personally never treated a patient with the tafasitamab because we don't have access to that drug, unfortunately, in my country. But it seems from the outside to be, despite perhaps not being super effective in the most aggressively sick patients, a very, very meaningful drug. And my understanding is, and correct me if I'm wrong, Gilles, that particularly in such patients that are perhaps a little bit frail and not easily accessible for the more aggressive treatments, can be a really meaningful drug. And then it looks again as a reminder of the luring problem that we always have with our patients, which is the immune suppression of our treatments, which sometimes end up costing the benefit of the drug.
I agree with that.
Yeah, I think the data has supported from an L-MIND standpoint. If you can get them to look like the L-MIND eligibility and you can get them after only one prior line of therapy, that's where the durability can exist. And that's where I've seen it in my clinical practice when I have used tafalen. I try to line up the check boxes, around that. And I think the real world experience is kind of saying if you don't look like the L-MIND data set, you should be planning on what you're going to do next after tafalen.
So let's go on to the next case. This is a 69-year-old man. What happened with him?
Yeah, so this man that I took care of for only a few months was a 69-year-old man without significant previous medical history, which unfortunately many years ago was diagnosed with both DLBCL and bladder carcinoma. At that time, he received local therapy for his local carcinoma and received 6 cycles of R-CHOP and completed the response in September 2014. He had a localized progression of disease in January 2015, and my colleague at that time used 2 cycles of R-GMOX and local radiation therapy, and the patient experienced a complete response that lasted quite a while. Unfortunately, his bladder carcinoma progressed, and he had to have a complex surgery with cystectomy and an ureteral conduit and sigmoid bladder. I tell that because you will see some PET images that because of that are a little bit more complex to interpret. What happened later is that in 2022, so, again, 5 years later, these patients experience retroperitoneal main nodes. Obviously, the question was that, is it bladder? Is it lymphoma? Biopsy showed GCB, DLBCL. And my colleague started on loncastuximab tesirine. I didn't look back to see how much Dex was given, Matt, but I think your recommendation is really meaningful. However, this patient tolerated quite well the 2 first cycles. And you should remember that this is a drug that is used at a higher dose for the 2 first cycle, 0.15 milligram per kg, and then diminished. And what you can see quickly here on this PET scan is that he had a really complete response achieved very well. Again, showing here on the right of this slide, this is the artificial bladder and all the apparatus of the urinary excretion. But all the disease that were here on the top and in other lymph nodes had disappeared this time. And if you look other sequences of the PET, you should believe me. So complete response in May 2022. And in terms of tolerability, I plotted here the values of hematological parameters. As you can see, the hemoglobin level, which was a little bit below the normal value, remained stable all over time. The platelets dropped significantly, but not to an extent that was concerning. And actually, at the end, and we'll discuss that when we stop the drug, they went back. The point that you made regarding sun exposure is really important. And actually, this patient had a skin eruption that was meaningful after sun exposure. It resolved with topical steroids. But I think we should really encourage these patients not to get on the sun or to get on the sun with significant sun protection. There was no abnormality of liver tests during the treatment. Well, the story is complete response that lasted more than 1 year. He was now 77. Unfortunately, again, these were frail patients, advanced disease, and he had a cerebrovascular accident in October, and his performance status decreased, and he was admitted to hospice without evidence of POD. So a patient that reached again a very rapid complete response, meaningful complete response that lasted with 1 year, a drug that was, I will say, very well tolerated. I should admit that I have used this drug very rarely in patients. I took these patients in the middle of his care. I continued until, unfortunately, he has this other accident. But I think this drug can be useful in some circumstances.
So, Manali, any questions? Any experience you want to relate to using this agent, both positive in terms of efficacy and in terms of tolerability?
Yeah, I've actually had a similar experience because the patient chose to not wanting to travel to Denver at my site, which was about 6 hours away. So there was no way I could give the patient a CD20 bispecific antibody because the initial starts happen at an academic center so far. And then when the risk of CRS abates, then second cycle onwards, they go back to our clinics in the community. So the patient said no for a CD20 bispec. They said no for a CD19. The patient had borderline MDS. So we were hesitant to do tafalen, and that's when we chose Lonca-T. And just as we saw in this case, the patient had a complete remission, and so far is tolerating the treatment really well. My question is, if you now have to choose Lonca-T at your site, do you consider combining it with rituximab? I know the label doesn't say it, but do you combine the two off-label?
Yeah, I start to be a little bit more cautious regarding reusing rituximab in my patients. I mean, we have significant number of patients that become CD20 negative. Probably we explore that more deeply with the bispecific. So I will say it's rather unlikely that I will offer this treatment to a patient that hasn't received bispecific. We are working with many community sites in New York still or in New Jersey to allow them and to teach them how to use bispecifics. But I will say it's rare that I tend to reuse again and again rituximab as much as I used it, I will say 5 or 10 years ago. I'm right, I'm wrong. I don't know. I'm talking only about the LBCL, not about follicular.
Yeah.
But, maybe you can do it. Whether it's a benefit or not, I think it's unclear.
Matt?
I think the one situation, based upon the Lotus-5 safety run-in, if they were a relapsed patient that had, kind of always responded to rituximab combinations, that data actually looks really, really compelling in regards to their CR rates, but it was a heavily relapsed population in Lotus-5. And I know that randomized trial is now almost fully accrued to see that data against R-GemOx. But I think that would be the only situation, Dr. Kamdar, where I would even consider adding rituximab to LONCA-T.
Before we go on to the last module, just to pick up on something that's come up a couple of times and get your thoughts on it, Manali, is particularly as it relates to both CAR T and bispecifics, sort of the role of the community-based general medical oncologist, particularly as it relates to bispecifics. We see patients getting started on a bispecifics, then going to the community. I wonder about, the community's ability at this point to be able to support these patients. We now have a CD3 bispecific approved in small cell cancer of the lung. So it's going to be very interesting to see how that's the first time, I think, in a solid tumor, tarlatamab. Anything you want to say about, what you see now and moving forward about the community-based oncologists, Manali, particularly with bispecifics, but also knowledge gaps that they have in terms of CAR T as well?
Yeah, so I think with regards to CD20 bispecific T-cell engagers, we are working so closely with our community clinicians across the 5-state area that my site caters to, that we have quite an algorithmic approach that we have developed, that if any patient needs a CD20 start with glofitamab or epcoritamab, we actually have them come to Denver. This is only for diffuse large B-cell lymphoma because the paradigm for follicular is a little bit different at our site. There's a little less CRS with Mosin, so we are a little more comfortable to have them go back to the community. But with regards to just relapsed refractory DLBCL, we keep them for the first part of the escalation. We use a lot of glofitamab as compared to epcoritamab. Just like Dr. Hutchings alluded to, you get a faster way to get to the more potent dose. With glofitamab, a lot of times our community physicians are able to do the pre-glofi obinutuzumab, which is 7 days before the first dose of glofi at their site. It gets fast. It is authorized faster. Then they come to our site, get the first 2 doses. And cycle 2, day 1 is the last dose. They get an academic site here, and then they return to the community partners. And that way, so far, we have had about a 40-patient run, and we have not seen any CRS that our community physicians have had to handle. Of course, patients get a lot of cards. They can call us at any time of the day or night. They know exactly what the direction they will have to go through if they experience any sort of delayed CRS. Although rare, it may happen in the second cycle. So that's been our algorithm for the CD20 BiTE. With regards to CD19 CAR T cell therapy, we definitely do a lot of 4-1BB constructs. As a result, we've been doing it for the past 8 years at our site. As a result, we have all the resources set. We do see less cytokine release syndrome. We do see less neurogenic toxicity. We are doing a lot of this in the outpatient setting, but so far we have been having these patients be treated exclusively at our site for the first 30 days. The next paradigm that we are going to look at is figuring out a way where we can partner with our community physicians and have the patients go home a little early. Who are those patients? What are they going to look like? Is just something that is going to be an evolution. But it's definitely a constant collaboration. That I have to say, it's rituximab. CD20 BiTEs are going to be the new rituximab. And with SkyGlow and StarGlow being approved, and eventually in the future, I think eventually CD20 BiTEs will have a place in the community, even for the first starts. It's just going to be a little bit of a learning, and then they'll be off to a great start.
And Neil, having come off of service last week, tarlatamab, we had to get a crash course in tarlatamab. And, I think the last time I saw a small cell lung cancer patient was in fellowship. So not a big, learning curve other than I think you have to understand their comorbid conditions, right? So their grade 2 CRS and hypoxia may be a little bit different in that regard. But my initial experience is fever, it's great, a lot of grade 1 CRS, but not a lot of higher grade CRS but they're admitted multiple times. And so we're really struggling from a resource utilization standpoint. And I think we need to continue to educate our general oncology colleagues that there's a tsunami of these bispecifics coming, and tarlatamab is just your ability to learn, before the big wave comes in.
Yeah, and it sounds like we did a webinar the other day, and we were talking about tarlatamab. They want to move it up and do maintenance as part of first-line therapy. So, as you say, it's really going to be an interesting learning curve. One other sort of clinical point, from a general medical oncology who is referring these patients, Gilles, for CAR T. We heard the case earlier of the homeless man that somehow they were able to marshal a lot of support for them, but what should a general medical oncologist be thinking about in terms of so-called social support? Like what is really necessary, and how do you get around that if there is a way?
Well, we have different ways to go around that, and things are not necessarily easy. Our hospital is very crowded, so we try to keep most of our patients outpatients. We have a residence across the street. So when the patient has, social support by family, friends, they have to stay with the caregiver in the residence. Sometimes, and this is a little bit exceptional and obviously leads to several approval at different levels, we find a third party being able to assist this patient during the stay in the residence, or during the first 28 days or 30 days of the care. So it had happened to us. It's better to do that with a patient that has some understanding and is able to share, a limited space facility with another person. But we have done it in several occasions. So I think the caregiver is a very important question. Besides that, I will say, for 1BB CAR and Lysocell, we tend to treat many patients in the completely ambulatory settings. They come every day during the first 7 days, and they don't have to spend time in the hospital unless they present a CRS. And even with the CRS, they don't stay too long. 3-4 days. I think we have really to be meaningful of how to manage this patient after day 20, 30. I agree with Manali. Probably we will learn that some patients at day 15, 20 can regroup to their community oncologist if they haven't experienced anything. I haven't seen many late CRS with 4-1BB CARs, at least the one we have right now. So I think we have to, if nothing developed before. So I think we have to learn still, and probably continue to manage this patient and organize pathway for this patient. But clearly the caregiver is a major issue.
We'll finish out here. Matt's going to review promising investigational approaches in this arena. Matt?
All right. Thanks, Neil. So it's nice being the anchor, and it's nice to know that I'm going to talk about new combinations which haven't been discussed to date. So here are my objectives. I'm going to speak to Echelon 3, and then I'm going to talk a little bit about golcadomide, and then go through a third bispecific. Martin mentioned a little bit with odronextamab, but in a special and hard population. And so with that, the first one we'll talk about is Echelon 3. And this is, the trial that kind of flew under the radar, I would say. Like got offered to a lot of us, but I think we, at least in my opinion, I didn't think it was going to, have much legs and not see likely the light of day at the end. I didn't expect it to accrue, but it did. And it actually had some interesting results that I'm going to go through here. And you can see it was in a relapsed refractory large cell population, 2 or more lines of therapy, and obviously had to have measurable disease. They could not have had prior brentuximab vedotin, again, which was compendium listed in the NCCN guidelines at the time for CD30 positive large cell lymphoma. And, I'd like to think back about when's the last time you called your hematopathologist and asked them to stain for CD30 in a large B cell lymphoma. Also, lenalidomide, was one of the backbones here, and R squared was and still is on the NCCN guidelines compendium listed. And at the time the trial was being studied, it was a regimen, R squared, that people were reaching towards in the relapsed refractory setting. A lot of it driven by a lot of the R squared experience, which was around kind of moving it into the front line, which we then knew didn't really pan out despite the randomized clinical trials in the front line. So you can see here, this was a 1-to-1 randomization of brentuximab vedotin, again, our CD30 antibody drug conjugate with a monomethyl auristatin E warhead paired with R squared versus placebo R squared. And I want to call out the stratification factors here where CD30 status was stratified. The vast majority of the patients did not have any expression or less than 1% expression of CD30. And about a third of the patients did have greater than 1% CD30 status. And so I think that that's something that we'll look at from a kind of a curiosity standpoint. And so this is looking at the patient population. And I think one of the things I wanted to call out here between the two groups is we're starting to see clinical trials now that have duly exposed patient populations that have both seen and relapsed or been refractory to CAR T-cell and bispecifics. And so this is a population that is de novo, and we don't really have a good footing on how well these patients are going to do. But I would argue that they're probably going to do quite poorly. Also, as I alluded to here, CD30 status, we had a lot of debate in the T-cell lymphoma landscape about the importance of CD30 expression and the activity of brentuximab vedotin. I kind of fell in the camp that I'd be willing in T-cell lymphomas to expose patients that were CD30 negative to BV because I've had and seen responses in this situation. So I was quite keen on kind of seeing these results, especially after seeing the outcome. The outcome here was positive, not only in favor of BV R squared in regards to a PFS, and you can see it here at 4.2 months versus 2.6 months. Again, understanding the patient population that we're dealing with, that still is a statistically significant outcome, even though short PFS at 4.2. But then you kind of think about where we were with POLA BR versus BR. In Echelon 3, there was actually an overall survival advantage also, and you can see it here at 13.8 months compared to 8.5 months. So on one hand, you can say it's an old, regimen, R squared. Who's using that anymore? But you know what? Maybe this is a regimen now with the addition of BV that will make R squared sexy again in relapsed refractory large B-cell lymphoma. But I don't think that it's going to be utilized second or third line based upon a lot of the other regimens that we talked about today, even if it does get an FDA label. We did look at, or it was looked at ASH this year about age, because I think we've heard a lot about the frail or those that can't travel, 6 hours to get weekly doses or get CAR T cells. And this looked at the outcomes not only by age greater than 65, but also by age greater than 75. One of the points I think that's incredibly important to think about, and Gilles called it out in one of his cases, was that creatinine clearance and lenalidomide, is incredibly important. If you have mild creatinine or kidney dysfunction, 30 to 60, the body will feel the 10 milligrams of lenalidomide, and you will be doing likely a disservice to the patient if you overdose them based upon their renal insufficiency. You will have significant side effects from that standpoint, and you'll automatically be dose reducing, or the patient will tell you they don't want to do that regimen again. And so paying close attention to creatinine clearance, I think, is incredibly important with the utilization of lenalidomide-based combinations. And this is the teaser that I was talking to you about. So what kind of stuck out to me was, and validated a lot of my historical thoughts, was that, by golly, no CD30 expression appeared to do better or equivalent to those patients who had more CD30 expression. So what was it about lenalidomide, rituximab, that made CD30 better in this? Or you just don't need that much CD30 to get activity with brentuximab vedotin? or we just do a really poor job of identifying CD30 with the BurH2 IHC from that standpoint. And so I think in the end, I don't know now if you have, if this gets a label, if you actually need to test for CD30, or you can just assume that you can utilize this regimen again if it gets a label. And the reason why I think it may get used in the relapse refractory setting is because BV really didn't add that much toxicity. You can see here perhaps a little bit more hematologic toxicity with neutropenia, thrombocytopenia, and anemia. And I think in this patient population and with this number of prior lines of therapy, you're probably going to be utilizing G-CSF support anyways. The one thing I will call out is the peripheral neuropathy was not that robust, but again, the exposure to BV was likely limited because of the limited duration of utilization based upon the short progression-free survival. And in my experience, with BV, you got to get into the double-digit doses before you start to see a lot of the peripheral neuropathy. However, in heavily pretreated populations that have seen, a lot of vinca alkaloids or a lot of other neuropathic inducing drugs, you got to keep that in mind. And so it'll be kind of interesting to see if this does get a label. The second drug that I want to talk about is golcadomide, and I really enjoy this drug. In fact, when I was making this talk, I had my 10-year-old, I was making at the dinner table, my 10-year-old saw this cartoon, and he's like, tell me, what is this, Dad? And at the time, Transformers was he was watching the Transformers cartoon. So I came up with the analogy of the Decepticons versus the Autobots. And, Golca is an Autobot and Ikaros and Ios is a Decepticon. And so what you can see is, the good guys, golcadomide goes and it blocks the Decepticon and basically sends it off to jail where it gets kind of, broken down into pieces. And that in itself leads to the activity. And one of the ways that golcadomide works, as you can see to the left, it kind of looks like a transformer, where when it's in the inactive open cereblon state, it's exposed like Bumblebee or Starscream would be. And Starscream's my favorite Decepticon because he's the Air Force jet. But when you add in and create the active closed cereblon through the Ikaros Ios binding, golcadomide is much stronger. And so that's where the Autobot phase comes in, as it doesn't allow the Decepticon to transform. And so golcadomide is the good guy. They're the Autobot, and here to save humankind, as just like our Transformers living in the shadows. So anyways, he really liked that analogy. And I've always struggled to kind of find something that helped explain how IMiDs and CELMoDs work. But it was kind of fun for me. So anyways, golcadomide, we found some early activity last year at ASH, but we knew it was probably a dose attenuation or a dose efficacy standpoint where you saw higher doses may lead to more responses from at least an overall response rate standpoint. And then later or just this year at ASH, we also saw this, and this kind of stayed with my Transformers theme, because this is where Optimus Prime being the leader of the Autobots, which would be the FDA, made golcadomide go through Project Optimus. As you can see here, many different doses, many different schedules to try to figure out what was the right dose of golcadomide. And then cohort C, you can see, which was in a relapse refractory DLBCL at 0.2 or 0.4 in combination with rituximab, with further studied in a much, much, much larger patient population. You can see here with tons of prior lines of therapy, median 4 lines of therapy, many of these patients also being exposed to CAR T-cell and T-cell engagers. And so really this is golcadomide's being tested here, I think, in the appropriate population in 2024 to 2025. And what were those outcomes? Pretty darn impressive. And you can see the dose contribution here. I think 0.4 is where it's at. You can see an overall response rate of 60% at 0.4, with 43% CRs. If you look at those overall responses by CAR T-cell, like we see with other combinations, if you've had CAR T, you see a little bit of a drop off. Again, if you've had prior CAR T, 33% CR rate. So not unimpressive, but I would think that this may be one of those that you'd be thinking about bridging to an allo transplant if you get that magical CR post-CAR, post T-cell engagers if fit. There was some toxicity with golcadomide. I think you see it with higher doses, mostly hematologic, from that standpoint. And the last compound I want to talk about with time waning here is odronextamab. It was mentioned a little bit in Dr. Hutchings' talk, which was, again, a CD3, CD20 antibody or T-cell engager. It's kind of the one that got left behind a little bit into the approval market, but I know it is accessible in Europe. And this is specifically looking at a post-CAR T-cell population. I think this is the unmet medical need right now, besides access to CAR T-cell in large B-cell lymphoma, is the post-CAR T-cell state. And that's why I wanted it to be the theme of my talk, is looking at the activity in this area. And here you can see this kind of, I call it the chutes and ladders type of slide presentation. But you can see even with odronextamab in the post-CAR T-cell state, you can see stable disease as well as PRs quickly by week 5. You can see by week 12, some CRs, PRs becoming CRs and stable disease being PRs. But you can't give up on this drug. In this setting, I've always thought that with Glofit and Epco, you knew very quickly. You often knew within 2 cycles. But I think this is giving, some data to say maybe don't give up in those stable disease patients, because they can, over time, still derive benefit. And you can look at it here, like we know the duration of response, as well as the duration of mostly CRs. It's driven by CRs. So if you can get these patients into ACR, that's where the CRs can be meaningful. And so it'll be interesting to see what odronextamab's next steps are in the United States, as it's kind of a crowded space in regards to relapsed refractory large B-cell lymphoma. And with that, I think that's my last slide, and to move on to some cases.
So before we get to the cases, I just want to turn to Manali and see if she has any comments on your presentations. I've got to say, research to practice around here, we consider Matt the king of analogies or the king of metaphors. He always comes up with ways that I can understand how things work. I was also just flashing on the fact that a week ago at this exact time, I was sitting in this exact chair doing this very, very similar think tank program on HER2-low breast cancer and the antibody drug conjugate trastuzumab deruxtecan. So this is not the only time when there's been a debate about how much target an ADC needs to work. But Manali, any thoughts or questions about some of the things that Matt went through?
Yeah, I will digress and say just 2 things. I am amazed at how proficient you are in every known tumor, from lymphoma to medullary cancer of the thyroid. It's just mind-boggling. And to Matt, yes, I have followed his presentations for a while, and they're just amazing. So I think he presented some amazing data with golcadomide as well as the Brent-Len. I will say that I use a fair amount of Brent-Len, exactly as Matt alluded to, in the post-CD19 as well as the post-plus CD20 BiTE space, where majority of these patients are cytopenic. They're not good clinical trial candidates by then. And if they are young, I have usually used this as a bridge to an allo, because the median PFS is quite short. But if they get to a CR, it's my chance to get them to an allo. So that's how I have used this doublet. And with regards to golcadomide, we do have a clinical trial, and I am beginning to see some nice responses. I think it belongs in the combination model, just like you alluded to. So golcadomide plus rituximab. There's also clinical trials going on with golcadomide plus CD20 BiTEs, and those are also looking very good.
Fascinating. All right, let's finish out here with a couple of cases from Matt, beginning with an 80-year-old woman. And Martin, maybe you can respond to this case.
Yeah, so this is an 80-year-old woman who presented with shortness of breath and fatigue. And, like many 80-year-olds that walk into the ER, they get admitted for further workup. She has mild CKD with a creatinine clearance of 45 mils per minute and some normocytic anemia. She has bilateral pleural effusions on her chest x-ray, and a thoracentesis by our pulmonary team shows a transudative effusion with flow consistent with involvement of a CD10 kappa restricted B-cell population. So, that's enough in our hospital to fire up the old PET CT. And she's got a enopathy above and below the diaphragm with extranodal avidity in the pleural space bilaterally, as well as a large soft tissue mass with an SUV of 20. So astutely, our residents order a biopsy of the pelvic mass because they understand that CD10 positive, could be anywhere from follicular lymphoma to Burkitt lymphoma, from that standpoint. And the pelvic mass is biopsied and it's a GCB, DLBCL by Hans criterion. It's negative for a double hit. She's stage 4A, GCB, IPI is 5. I often think that these IPI 5s are narwhals. Those things actually exist, but you rarely see them. I used to call them, unicorns, because you talk about them, but you never see them. At least you never see IPI 5s in clinical trial. So anyways, this patient got a polar chip for 6 cycles. And her end of treatment PET CT showed a metabolic CR. So we were like, woohoo. But then she had MRD assessments, and she still had residual detectable sequences. And so, that's kind of what we're doing. And so, in this situation, because she had kind of, got better, I thought she'd be a CAR T-cell candidate. So we just watched her with short interval PET CTs, and lo and behold, 3 months later, she has emergence of low burden avid lymph nodes with minimal pleural effusions. So again, she has large B-cell lymphoma, but she defers CAR T-cell despite my okay, we're going to catch you closely. I think you can get to CAR T, because of logistics. And, she was 300 miles away and I couldn't convince her to stay in Omaha for 28 days. And so we actually convinced her to do, GlowFit GemOx. So a Star Glow, like approach. And lo and behold, she tolerates the step-up dosing well with GCF support. At cycle 4, she has a PR. But then at cycle 7, when she's closer to home and the community oncologist is giving the GlowFit, because they had dropped the GemOx after a couple of cycles, due to intolerance, she has progression of disease. So she's looking for something that does not require frequent visits to her oncologist, but wants further treatment. And so, I did go back, and test for CD30, regardless. And it was, I think, 10%. EBV was not, present because I know there's some papers on EBV and CD30 co-expression. But, we've heard a lot of the options today. And I wanted to hear what, my colleagues would do in this situation.
Martin, any thoughts?
Yes. It's a shame she didn't want the CAR T, right? Because if she doesn't want to come frequently to the hospital, a one-stop shop would be a nice, even with 300 miles. But it's intriguing that you find 10% or more expression of CD30. And it leads me, and sorry to derail it a little bit here, it just leads me to ask you now that you mentioned the Echelon 3 study, which I think was mind-boggling to one of us. With a benefit which seems to be at least as good or maybe even better in the ones with very low expression of the target. Do you think it's just because MMAE is a bloody potent drug? And perhaps we should learn to give that drug at micro doses, just like amphetamine is done among the young people. And then it would be really useful. And maybe the antibody is just a very expensive way of delivering it.
Yeah, I think there's a lot of bystander or effect with MMAE from that standpoint. And it is interesting to microdose. Do we need to go back and try to microdose some of these very potent drugs?
I think
has that ever been done?
So MMAE originally, and we're back in the late 1980s, was attempted, developed, but never clinically, because as far as I remember, most of the animals in the animal models died of severe cytotoxicity. But that's a dose dependent effect, I suppose.
Yeah, no, I mean, a lot of people have heard that story, but did they actually look at micro doses?
No, I don't think so.
It's back in now.
Yeah, I think we should not forget that there is a population of T cells that express CD30, and there may be some immune effect with the combination of R-square. I still have questions when I look at this data, the toxicity of this regimen in terms of heme toxicity, infections. So I still don't know exactly in which patient I will use it. Your patient is very refractory to anything. So, probably not a very good candidate for tafalen, but, if she doesn't want to come too often, at least to a center, that's the case. But tafalen is demanding. They come very often at the beginning. So maybe Lonca could be a good opportunity, or this regimen that you mentioned.
Yeah, I think that was what I was struggling with. She was CD19 naive, right? We hadn't perturbed or picked on CD19. And so that's why I was thinking, with regards to Lonca. But then, and that data actually looks like it had, the age doesn't matter with Lonca either. I mean, this looks like the 75-year-olds, did and over did just as well as the 55-year-olds and 65-year-olds, with that drug. So, but also, then the CD30, I threw that in there just because of the kicker of like, it doesn't really matter.
So what's this patient's current situation? You decide what you're going to recommend?
Yeah, so this patient is getting Lonca out west, a Lonca TDEX, I should say, and being supported in the community.
Before we go on to your next case, just to come back to you, Manali, any comments again to educate the general medical oncologist of the role of MRD assays in diffuse large B cell?
Yeah, I was actually going to pick on Matt with regards to the end of treatment MRD, because there is just so much research and clinical trials happening in that space. We talked about the new constructs that are developing in the CAR T world, and one of them is the allogeneic CAR. And initial results with allogeneic CAR were demonstrating promising efficacy in patients with relapsed refractory large B-cell lymphoma. Just for our audience, I think the AlloCAR is basically T cells that you get from the donor, so they are very fit. As a result, it's off the shelf. There is really no manufacturing time. The issue with AlloCAR used to be about a concern for rejection, graft versus host disease. That has certainly not been the case because of the CD52 and the TCR knockouts. So the company decided to actually test it in a clinical trial in a phase 3 way, where they for patients who have finished our chemotherapy after receiving it for diffuse large B-cell lymphoma in the frontline setting. If they are wanting to enroll on this study, you look for MRD. And if MRD is positive, but the PET is negative, then they are eligible for this study, where they get randomized one arm to the AlloCAR and one arm to observation. And when they relapse, they have the ability to go to AlloCAR. So it's a really cool concept to bring in CARs when the tumor burden is minimal. We don't know what the results of this study looks like. But even more interestingly, I think the recent NCCN guidelines were updated, and the end of treatment MRD is now on the NCCN guidelines. It's using the PhaseSeq assay that was developed in the David Kurtz and Ash Elizadeh lab. So I think we're all learning how to use MRD, what to do with an MRD positive but PET negative patient. Exactly like what Matt did, like Dr. Hutchings alluded to, it's unfortunate she didn't consider CD19 CAR T, because that would have been the perfect time to consider it. But I think the role of MRD at the end of treatment is going to be practice changing, in my opinion, in the next couple of years.
All right, well, let's move on and finish out our program here with this 54-year-old man, Matt.
Yeah, so this gentleman presented with left arm weakness. Obviously, thought he was having a stroke, but had an MRI, which of the brain and cervical neck, and caught just the top of a left upper lobe mass, and that mass was pressing on the brachial plexus. There was no Horner syndrome, though. I haven't heard that since reading through some of the medical school textbooks and thinking about it. So thank you, Dr. Hutchings, for jogging some neurons today. His labs were unremarkable. The biopsy of the left upper lobe mass was diffuse large B-cell lymphoma, non-GCB phenotype by Hans IHC. PET scan showed adenopathy above and below the diaphragm with extranodal activity in the left upper lobe, and bilateral adrenal uptake with a metabolic activity of 20. He had, if you're looking at the NCCN IPI, this was a high-risk patient just based upon the LDH would have gotten him a ton of points here. So this is a very bad large cell lymphoma. He was negative by FISH, and he had a negative MRI and LP, because of the bilateral adrenal uptake. And I think we could have a full hour discussion on what to do, with regards to prophylaxis when you know that this guy is at high risk for, if he doesn't have CNS disease now, CNS disease in the future. Nevertheless, he went on to get Pola-R-CHP for 6 cycles, or was planned for 6, and he had an interim PET CT prior to cycle 5 that had new lesions in his liver. And so I thought this was going to be some sort of an infection or something like that, because resolution of all the other lymph nodes and all the other extranodal sites of disease. And I think that this points out is just how darn tricky, these our lymphomas are, and when there's, incredible amount of nuance in the management. So, I kind of called a timeout, and I decided to biopsy the liver, and god darn it, it was the large B-cell lymphoma. Just kind of bizarre. These primary progressive, cases here are just, less than 5%, but when they happen, they happen. And so he proceeds to CAR T-cell with pre and post AVE GEMOX bridging. He has grade 2 CRS and grade 1 ICANS with mild cytopenias at day 29. He has a day 29 Deauville 4, and this is where I wish I had a trial, right? Because this is exactly where I would want to use glofitamab or some CD3, CD20, but wasn't quite there yet. And of course, at say 100, he has a Deauville 5 with progression to disease. And so, thinking about the data that Dr. Hutchings, had presented, a lot of the GloFit, a lot of the EPCO patients didn't get into the trial. They had to, I think, 2 months, post-CAR T-cell. But now we have the trials, that allow, for bispecifics early in the PRs. And I'm just curious, is anybody starting to do that on day 29 scans if they aren't, or are they even doing day 29 scans after CAR T-cell?
Yeah, it's interesting. I saw one of these patients like that yesterday, actually, Matt. And, we do know that some of these patients convert. Yeah. And, whether you need to intervene. So for these patients that I saw yesterday, the answer was he had already received bispecific, because we was really failed to go to CAR T, and we went to a kind of modified Starglow regimen before to CAR T, which didn't work. So I wouldn't say. I have another patient like that, who I treated with CAR T rapidly after failing Pola-R-CHP, with minimal bridging, actually radiation therapy, which I started bispecific based on the Deauville, which is probably more 4-5, with a new biopsy. And I was fortunate to obtain also LEN, so she's starting on Glofin-LEN today.
Yeah, I think to Manali's point, one of these things at day 29 I've started to scratch my head is can we be doing CAPSEEK or clonoSEEK, and utilizing that to say go, no go, if there's detectable sequences. But that's still, kind of more in my neurons. I haven't done that to treat or not treat.
Martin?
Yeah, I think it's extremely difficult to extrapolate from the data we have from the studies of the bispecifics to this situation, because I completely agree with Gilles. The 33 to 40% of patients that had previously been exposed to CAR T in the bispecific studies, they were not rapidly refractory to CAR Ts. They failed, but most of them had some kind of response, or at least a long duration, because that was mandated, like you say, in the protocols. I think it was 3 months, 90 days or something. But I think it's an interesting idea and an excellent proposal to give the bispecific early, and ideally maybe even from the beginning. We've never seen CAR T and bispecifics combined.
Mm-hmm. Not yet.
But there's not really a good reason why we haven't, other than competition and fear of side effects, obviously. Yeah. But I don't see why it shouldn't work. And of course, you should not add both components to maximize the risk of CRS, but to give the bispecific at a point in time when the patient needs more anti-tumor effect, and while there are still active CAR Ts in circulation. I think that's a brilliant concept, and this would be an opportunity to show that in practice.
Yeah, the irony is we have that trial open. It was like just like a couple of months too late in this situation.
I think I should add to that I mean, at our institution and many others, we monitor CAR T, or we are able to monitor CAR T. I have seen patients with rebound in their CAR T circulation after bispecific exposure. And I agree. I mean, initially we were very concerned about potential rebound of CRS and things like that. I think we are still at a much lower level than what happens at day 15, but I will be very keen to start bispecific quite early.
Yeah, completely concur. I also feel that, the quality of the partial remission needs to be really studied. Back to Dr. Hutchings' point, I don't think we do a good job in identifying which partial responder is actually not going to be a good player versus which partial responders might actually convert to a CR. So I think we need better clarity there. And there is actually a cooperative group study addressing exactly this question of what to do if patients achieve a partial response or stable disease after having gone through CAR T at day 30 and more. It randomizes patients to getting Pola-R or Mosun-Pola or Mosun alone. So I think that study, I think at that point it wasn't available to Matt, but for the general medical oncologist on the forum here, I think it'll be very helpful.
This concludes our program. Special thanks to our faculty, and thank you for listening. This is Dr. Neil Love for Striving for Consensus.